Dr. Pramila Madam, Professor and HOD, Department of Biochemistry from the Institute of Child Health. To felicitate Dr. Shubha Karthikeyan Madam, Senior Consultant Neonatologist, Madras Medical Mission. Inviting our first and renowned speaker, Dr. Shubha Madam, who's a senior consultant neonatologist from Madras Medical Mission, Chennai. We invite Dr. Prem Kumar Sir, HOD, Department of Biochemistry, to felicitate Shubha Ma'am. Madam has done her MBBS in Madras Medical College, Chennai, DNB in Pediatrics in Child Care Hospital, Chennai, Diplomat in American Board of Pediatrics in Wayne State University, USA, and acquired clinical fellowship in the University of Calgary, Canada. Madam has published many papers on neonatal ventures like aortic thrombosis in neonate and other congenital heart diseases as well. I once again invite Dr. Shubha Ma'am with pride to talk on the topic Pivotal Approach to Neonates with Inborn Errors of Metabolism. I also invite Dr. P. Kanagavalli Madam, Professor and HOD, Department of Anatomy, and Dr. Sridevi Madam, HOD of Pediatrics, Government Medical College, Thiruvallur, to chair this session. I once again welcome Dr. Shubha Madam with pride to talk on the topic Pivotal Approach to the Neonates with Inborn Errors of Metabolism.
Am I audible? Yeah, okay. But Narendra is Good morning. Shall we all settle down for me to start talking? Yes. Good morning to one and all today. I'm really honored to be here. I would like to thank all the faculty of Thiruvallur Medical College and all your students to be present in the CMA today. Um, It's a real pleasure. It was learning to teach you people a little bit a general approach of inborn errors of metabolism. I hope you would all done your pre-tests and you'll gain some insight after my talk to do a better job in your post-test session. Okay? So starting off, I am basically a neonatologist, so I'm just going to do a basic approach on inborn errors of metabolism. It's just a fundamental talk on how to approach a child which you think could be a metabolic based on certain pointers. And we start off a basic investigation, and then through the day, you're going to have so many people talk on each subtopics like how to investigate them, how to read the algorithms for different metabolic disorders, and what are the treatment options available, and things like that. Okay, so starting off my first slide. Okay. Definition. So, inborn errors of metabolism. Say inborn, so we think all of this have a genetic basis to it, right? And it is a disorder of metabolism. So, there is some block in the chemical pathway which is causing this whole metabolic problem. So, if we take that into consideration, so let's say this is the substrate and then we have the product. So where is the problem? The problem could be in the enzyme which is catalyzing this reaction, right? So the enzyme could be a problem with defective enzyme, or the cofactor without which the enzyme can't function. That could be the problem, right? Or finally, a genetic basis, a gene which is coding for this enzyme is a problem. So there could be a genetic disorder leading to a deficient enzyme or a cofactor deficiency which could cause the problem in the enzyme. So ultimately what happens? The substrate is increased in concentration because the product is not formed. So this is the basis of metabolic problems, right? So it's different ways we're going to handle this problem. Okay, so just for an example, like all of you are very familiar with PKU because in your biochemistry exams, I think it's a highlight question. So if you say PKU, so if phenylalanine gets converted to tyrosine, so the enzyme here is phenylalanine hydroxylase. The cofactor where whatever we require for the phenylalanine hydroxylase to function will be tetrahydrobiopterin. So the problem could be in this enzyme, this cofactor, or it could be the gene which codes for this enzyme, which is causing the basic problem in this condition. So this in turn causes this substrate to accumulate and convert into intermediate metabolites which can be toxic to the body, and that is what causes all the problems or symptoms of the metabolic disorders. Okay, so this is toxic accumulation of these amino acids which is going to cause all your symptomatology in these inborn errors of metabolism basically. Okay, to talk about a little bit of incidence. Um, there are a few articles on incidence of metabolic disorders in India, varied incidences. Some quote up to 1 in 1,000, some quote 1 in 2,500. Why we are not able to estimate a correct incidence? So the point is, I partly trained in the West. There they have centralized metabolic screening. Like a state has a central metabolic database where the screening is done. So what happens is all the metabolic screens of every child born, every newborn born in that state goes to this central place. So if there is a positive tyrosine or is a positive PKU or a positive any other, even a thyroid, the database is entered for that newborn in that particular state. So they have a huge database of all the newborns in that particular state, and then they can put it together as a full-time database. And so if there is a child born and this child tests positive for either tyrosinemia or PKU, the physician can quote the data to the parents saying, see, the incidence of tyrosinemia in this particular state is so and so, because we have a database of all the newborn screenings. But unfortunately, in India, it's all segregated. We have different, places doing newborn screenings, and we don't have a centralized database. But there is this Dr. Latif who's trying to put up something called a database in inborn errors of metabolism in a state of Andhra Pradesh. He started it off sometime in 2010, I think, and is trying to put in databases of all the inborn errors which are becoming positive, or all the data in a particular database. So in the future, we might have good databases to, counsel parents and ourselves know the incidence of what are the common inborn errors of metabolism in India. We have some data saying that some are common like tyrosinemia, some PKUs and MSUD, but we'll get a good huge cohort so we can have good incidences, okay? So going on to the next slide. So who is this great person who coined this inborn error of metabolism? So he's an English physician, Archibald Garrett. It was a very nice way. He was working on alkaptonuria. I think all of you know alkaptonuria, where the urine turns, dark colored in exposure to air. There is a, metabolism error in in proteins. So this person was following up kids or newborns with alkaptonuria. He had a huge cohort from different places of UK. And when he was doing it, he found out that siblings had the same disease and closer relatives had the same disease. So when you put all these cohorts together, he found out there is a genetic basis to these metabolic disorders. He not only worked on alkaptonuria, he worked on cystinuria, pentosuria, and other disorders, and he found out that there is a genetic basis for most of these metabolic disorders, and then he coined the word of inborn error of metabolism. Okay? So basic classification for a medical student. So if we think of metabolic disorders, I know even for me it's a very confusing topic. I know people, biochemists and people like from the genome might know all and everything about these metabolic disorders, but for us it's just a basic classification we need to know, which we can just categorize and try to get to some diagnosis. So we just classifying it as carbohydrate disorders, protein, fat, macromolecules, vitamins, and purines and pyrimidines. So this is a basic classification we can initially categorize a newborn. So based if this hypoglycemia, then I'll come up to all this in extent after this, but just basically categorize based on what we know in our basics about. If it's a carbohydrate, it could be GST or galactosemia. If it's a protein disorder, we think of amino acids or organic acids. Fatty acid, then we require carnitine for a transporter, so carnitine disorders or ketolysis disorders. Then we come to vitamins, which a lot of vitamins are cofactors for a lot of enzymes, so they can have problems. Then we come to macromolecules. So we know lysosomes and peroxisomes are loaded with enzymes, so deficiency of these enzymes are going to manifest as disorders. Then finally, our DNA, purine pyrimidines, which can have problems. And so this is just a broad classification. But we have specialized classification done by metabolic specialists based on certain, when they're present and what is accumulated and how they're present. So these are called the intoxication disorders, energy insufficiency, and macromolecular or dysmorphic defects. So when we go to the intoxication, this is the commonest we see in the neonatal period. So if we go back here, I was talking about the substrates and the accumulation of intermediate metabolites. This is what happens in the intoxication. So what happens, these substrates get accumulated, these substrates get converted into intermediate metabolites. These intermediate metabolites act as toxins to the body and produce all the symptoms. So what happens? Initially, the baby is born. Baby does not have symptoms because the substrate accumulation has not occurred enough to cause the symptoms. So these intoxication problems generally have a symptom-free period. So the baby is born well, goes home, then comes back one day with symptoms. So basically, they are presenting in neonates who are going home and coming back in a week or two with symptoms, and they are basically encephalopathic type. Okay. Triggers, depending on the disorder, could be an intercurrent illness which can trigger the admission, or it could be food. We all know like things like galactosemia. Initially, 3-4 days is not enough breast milk to produce symptoms, and then the breast milk goes in. Then we have the problems of symptoms. And the disorders which are more common in this intoxication group are amino acid and organic acidemias and some carbohydrate problems. Most of them are treatable, or you can do something to take away the intoxication or the intermediate metabolites out. The next group is the energy insufficiency group. Here, the products, the substrates have to break down to produce the energy, which is not happening. The energy is absent, or there's not enough energy, or the energy uptake is a problem. So here, mostly there is no symptom-free period and they can present at birth. And mostly fasting is a trigger. Fasting, fat utilization, ketosis. So they present, because of that, they present with hypoglycemia and they can present with lactic acidosis. They can be categorized as mitochondrial or cytoplasmic. So we know all the chains occur in the mitochondria, right? All the cycles in the mitochondria. So those cycles which are all having a problem, and cytoplasmic cycles, these are the problems which can occur in the energy insufficiency category. And these other pointers of an energy insufficiency category will be the involvement of liver, hepatomegaly, cardiac failure, cardiomyopathy, rhabdomyolysis. So these are all pointers that we are going in the pathway. This child is having symptoms in this particular pathway. That gives us a clue. Okay. The third is the dysmorphism or the macromolecular defects. In this defect, it's mostly these lysosomal storage diseases, peroxisomal like Zellweger's, cholesterol synthesis problems. So generally, they do not, very rarely they present in the neonatal period, but they present with dysmorphic changes. So baby does look different, which you can classically make out, and that can give you a big pointer that this is this category of metabolic diseases. They are not related to food, and hepatosplenomegaly and bone marrow involvement can be a important thing in this, like in Gaucher's and other conditions. Enzyme replacement therapy, which is going on, and also a lot of stem cell transplantation has been going on in a lot of storage diseases. So as I just talked about, most of the presentations in the neonates are CNS symptoms. They present lethargic, not feeding well, not easily arousable. Sometimes they can have seizures, totally comatose, encephalopathic. That's how the commonest presentation. But some, about 50% and odd, can present with GI symptoms like vomiting, diarrhea, and kind of symptoms, but finally end up with encephalopathic state, or it could be a mixed presentation. So this concept I thought was very interesting, and all of you should know why some metabolic disorders present at birth and some do not present. So this concept of placental protection. So we know that placenta is a beautiful organ, right? It takes off all the toxic metabolites out of the system of the fetus, right? So even in these fetuses, like a fetus has PKU, the enzyme is deficient. So the intermediate metabolites are going to be formed. But what happens? This placenta is a beautiful organ which takes away all these toxic metabolites out of the fetal system. So when the baby is present, the baby is not having any symptoms. But the child goes home, then it's out of the placenta, there is no protection there, the baby starts presenting. But there are certain disorders which escape this placental protection mechanism, like non-ketotic I read it in this article, which is very interesting, I wanted you to know. like non-ketotic hyperglycemia, lactic acidemia, glutaric acidemia, because the intermediate metabolic defect occurs in the cerebral, in the brain. So the intermediate metabolites toxicity has already occurred to the fetus in the brain, and very little of the intermediate metabolites come into the body fluids for the placenta to dialyze it out. Okay, so these conditions can present at birth because the placental protection is skipped. It cannot happen. Okay, so that is an important thing we all have to remember. Okay, so I don't know how am I going to diagnose a metabolic. A mother is bringing a child who is, in encephalopathic state. How do I know it's metabolic? Definitely, we will not. All of us, even as a physician, all of us have to think of differentials, rule out the differentials, and come to a diagnosis of metabolic disorders. But what differentials you have to think of? You should know before you investigate for the other causes, excluding these. So, sepsis. Neonates mean sepsis, so we can't separate it. Any baby comes with distress, any baby comes with any symptoms, the first thing we do is evaluate for sepsis. So sepsis can present in any number of ways in neonates. They present in shock, they can present with distress, they can present with hypothermia, they can present with any number of symptoms. So sepsis should be a first and foremost diagnosis in a neonate who presents. Okay. Next is cardiac. So cardiac, especially ductal dependent cardiac lesions, when the duct closes at about 3 or 4 days, they can present with shock. Lots of ductal dependent coact and TGAs or TAPVCs, which are TAPVCs is not really. So they can present in shock, and they can present limp, and they can have seizures because of hypoxic seizures and present like a metabolic. Then ingestion mainly. So in India, we have a lot of native medications which are being given by grandmas of the children, and I think I'm I'm not very sure, but Vasamba is one medication which lot of families come and ask me whether they can give. Earlier, they were given as, it's called a child protector, I think. So it's given for every ailment. Child cries, they think it's a stomach ache, they give. Child has some other problem, they give. But this is supposed to be associated with seizures. So, very important question when a neonate comes in the state of shock or in seizures or encephalopathic, should be, was there any native medication given to the child? Very, very important. Then we can track it down and see what kind of medication it is and look up. Okay. Then congenital adrenal hyperplasia. We are doing, lots of centers are doing it in our newborn screening, so we should be able to catch it before the child comes in presence with shock. Drug withdrawal. So I'm not very sure whether this is seen a lot in our country, but in the West it's a very, very common phenomena. Lots of mothers we see are on abusive drugs. So as long before the birth, the child is in the mummy's tummy, it gets a slow infusion of the drug. But once the child is off, cord is cut, they can show withdrawal symptoms. Withdrawal symptoms can be as severe as seizures and encephalopathy. But some babies just have hyperactivity, increased tone. So we have something called neonatal abstinence scores, which we monitor, and sometimes we end up giving low dose morphine for these children so that the withdrawal symptoms slowly come off and then they excrete the drug from their system. Okay, so now we finish with the differentials. Let's go. What are we going to ask for history in these parents when the child is presented with encephalopathy or other symptoms? So we know metabolic diseases are all genetically driven, mostly autosomal recessive. So consanguinity is the key. Very important question is consanguinity. Very, very important. Some mothers who carry neonates with long chain fatty acid disorders, they can have HELP and antenatal fetal liver disease of pregnancy. HELP is like low platelets and in hypertensive mothers, low platelets and other symptoms. So these two conditions are associated with long chain fatty acids, neonates presenting with long chain fatty acid metabolic defect. Family history, very, very important. So, lot of mothers come with unexplained neonatal deaths in the family. That's very important to ask. What day of life? How did the child present? Was it taken to an institution? Was the child evaluated? That's very, very important. Gives us a very good clue. There are certain centers which evaluate these infants and they have something on paper saying this was done, this enzyme level was done, this could be probably this. They would have been asked to do genetic counseling for the next pregnancy, but some parents don't follow up. So that's a very, very important history which will give you a clue of whether we are dealing with metabolic. Very, very important. Age of presentation, as we talked about the different varieties, intoxication and energy insufficiency. Age of presentation of this infant, of this neonate and the previous one which they lost, and what kind of symptoms they were. The child presented with what day of life, and was it triggered by what? Was it triggered by fasting? Did the child have an illness? Was it after the child started having full feeds? All these questions will give us an idea. If you go to the pediatric age group, which I don't want to, but you can get infants with failure to thrive and developmental delay with some dysmorphism, which can point to metabolic. Clinical signs. So you have this neonate who has a history of, maybe a positive consanguinity with a sibling who they've lost with some metabolic disorder, which we don't know. And we're going to examine this infant. So you're going to look at a child who is lying there encephalopathic with some stable vitals. What are you going to look for as pointers of metabolic syndrome? Okay, first, some dysmorphism. As I did talk about earlier, dysmorphic metabolic syndromes do not present in the neonatal period, but there is some, I have seen one ICEL disease, which is I think mucolipidosis. They can present with classical dysmorphism, bony abnormalities in the neonatal period. And you can see the child looks definitely different. Then you can think of a metabolic and work up this child. Others mostly present a little later in life. Then we'll, okay, this, you've looked at the child and what else? You can ask the nurse, what did the urine color look like? What was the odor like, right? The urine color and odor gives us some clue. So color, we know, we did talk about alkaptonuria where you can have a dark colored urine, right? The other thing is some metabolic disorders can have muscle breakdown called rhabdomyolysis. So they can have what's called a tea colored urine or a Coca-Cola colored urine. So color can give us some pointers of a metabolic disorder, but not a normal urate crystals which we see in newborn because of dehydration, but a classical tea color or a black color urine will give you some pointers. Odor, I think all of you would have had these questions in your exams. What is the odor of MSUD? What is the odor of thyrosinemia? But odor does point out to different metabolic, like a maple syrup. I just saw a poster outside saying MSUD for a different odor. And I don't know how many of you have smelled maple syrup because it's basically very Canadian. But he had mentioned some other odor, I don't know. Fruity youth. It was very smart, right? All of us don't smell. Even I, as a medical student, hadn't smelled maple syrup because maple syrup is in Canada, right? But that fruity ether odor. So I think I've not seen one, but those kind of odors, if you have it in mind, something different from the regular urea smell in the urine should be a pointer, I think, presume. And it has each own metabolic conditions which they can go into. Tachypnea. Is the baby fast breathing? Why can the baby fast breathe? Baby can breathe fast because of a respiratory cause, or it can breathe fast because of a cardiac cause. So what cardiac causes? What cardiac metabolic diseases? So Pompe's and glycosylation defects can have cardiomyopathies. So because of cardiac failure, they can have liver congestion and they can have a respiratory difficulty or distress. Then metabolic acidosis itself, they can have a fast breathing, right? So conditions which can cause metabolic acidosis or lactic acidosis, they can cause a fast breathing, like organic acidemias and mitochondrial defects. Respiratory alkalosis, especially in urea cycle disorder, the hyperammonemia, which I'll talk about later, can trigger the respiratory center and let the baby or stimulate the baby to breathe faster. So these conditions you should think of at the back of your mind when you see a baby with fast breathing. Okay, then skin. Okay, so how does the skin look like? Jaundice. Neonates do have jaundice, but significant jaundice, which the baby looks very yellow. Could be a sign of hepatic failure because of hepatomegaly or something like that. Bleeding, which is again a sign of liver cell failure causing all the coagulation factors, which is liver cell dependent. A significant rash and some fatty acid metabolism defects. And big abdomen. right? With hepatosplenomegaly, a huge hepatomegaly, in a lot of storage diseases, in galactosemia. So those are all the pointers which might guide you to one of the metabolic syndromes which we are going to face. Okay? Sariyave? Okay, fine. So you have come to you have come to some consensus. You saw the baby. You have a history in your background pointing to a consanguinity or a metabolic disorder. You have something on physical examination which is pointing out, and you want to investigate this child. I think you won't have all these luxuries to do all this when a child is encephalopathic. You might have somebody to do all this. But first thing you will do in a neonate who is sick and encephalopathic will be a blood sugar. All of us will do that to make sure the blood sugar is fine, right? So first thing will be your hypoglycemia at the bedside. So when you see hypoglycemia in a neonate, what would you do? You would want to do a confirmatory serum glucose or send critical hypoglycemia labs. Now with a history of a metabolic, questionable metabolic in your background, before treating this hypoglycemia, you say the sugars normally for about less than 45 milligrams a deciliter at the bedside, we treat a neonate immediately with D10. So we would immediately draw labs to make sure the sugar is, serum glucose is sent with some critical labs like insulin and cortisol. And what other additional labs would you think before you, for a metabolic syndrome? Very importantly will be a blood gas. So definitely you want to go through a septic line. So you want to do a CBC and a culture and a CRP because we were thinking sepsis as the first differential for metabolic. The next would be to get a blood gas and an electrolyte panel. So what will these give us? So you've looked at a CBC, you think, okay, fine, there is not big septic picture there, CRP is normal. Then we are looking at a blood gas. Blood gas will give us acidosis. Whether there is metabolic acidosis, is the pH low or it's alkalotic pH. This itself will give us a differentiation whether we're doing in the acidotic child or child with respiratory alkalosis. Next, we're going to look at the lactate. That will give us there is increased lactic acid. The electrolytes again will give us an idea about acidosis and the presence of a wide anion gap more than 12 or 15. Right? So these pointers will give us a lead to the diagnosis based on the flow sheets coming. So we're going to do a sugar followed by a septic screen, a blood gas with electrolytes. We can also do an LFT to see whether there is liver cell derangement, which will give us an idea. And what else? If we see some respiratory alkalosis in the blood gas, then we're going to do a ammonia 2 in the direction of a urea cycle disorder. So other and biggest thing after that will be a urine. So what will the urine give us? The urine gives us very good pointers for fatty acid disorders. First thing with galactosemia, you can see a reducing substance. In fatty acids, we will know whether the ketones present or not. It will really give us a very good idea, right? Then additional second line will be all these things. Urine serum amino acids, urine serum organic acids, carnitine profiles, CSF studies for non-ketotic hyperglycemias and other things. Finally will come the enzyme assays and DNA studies. Just to point out, it's being neonatologist, I think I should, before going to the management, think about what is the universal newborn screening going to help us with, right? So these are very, very important as a prevention for all these intoxication defects because you have a history in the family of a sibling death and you know something is going on, then you can do an extensive panel and capture these babies early. And if we have a treatment option available in India, we can do that and prevent the child going downhill and give them a quality of life. That is what is a newborns. But this wonderful thing, in our country, initial screening is done only for about 5 to 7 disorders in a lot of centers, except in some centers, if they do a stem cell antenatally, then the babies who are, the mothers give the stem cell in some corporate setups, the baby goes through the whole panel of 20 metabolic disorders with, TMS for both blood and urine, and sometimes you get one weird thing positive and then you do a confirmatory test. But most of the centers, maximum 5 to 7. But that's not the case in the West. I was just talking to you about where about 25 to 50 disorders are screened so that even if it's negative, they know the incidence or prevalence of a particular disorder in that particular community. So who found out this fascinating filter paper test? This was Dr. Guthrie, Robert Guthrie. He was a microbiologist. He had a child with mental retardation. And he thought this child had PKU. And then, but it was not it. But he had a niece or a nephew who had a PKU. And he was the one who started this screening for the newborn screening with the filter paper test. And now we do this filter paper test and we're able to find out, we're going to able to screen so many disorders at the same time using the tandem mass spectrometry, which was found in the 1990s. So high sensitivities, better to be like that. So even if you have false positives, we're not missing the true positives, right? Early detection improves quality of life. And in the American College of Genetics, you go to that page, you will have an act sheet for every metabolic disorder, where if you know there is something positive, you'll go in and see what should I do for this baby. Should I prevent this? What kind of diet should I give? What should I prevent? So there are a lot of act sheets there which gives us an idea, okay? This is just for future reference. If you know you're drawing all the first preliminary labs for this baby, you're getting some contributory results and you want to treat this child. The child with hyperammonemia, you want to treat it and you want to store some samples for the future. And you don't know what to store, how much to store is. This is what it is. So you can have one filter paper test which you can do for TMS for other disorders. You can have heparinase and EDTase bloods available, some urine frozen, CSF stored. All this not only for a live child, even for a child who has passed away because of a metabolic disorder, because of late referral or something. You can store all these bloods and these biopsy specimens, which can actually be very useful for the parent. You can store them and send them later also, but please, if you have a child we've lost because of some disorder, we have a question whether it could be metabolic, these samples can be so valuable for the parents for their future pregnancy, for a genetic counseling. So any form of biopsies which can be obtained and stored and sent would be very valuable for the family, okay? So this is what we have and we are going to see whether we can categorize them. What are the key points? So fatty, for carbohydrates is pyruvate, carboxylase and things, hypoglycemia, acidosis, lactemia. These are the key things you're going to see, some amount of ammonia and ketoacidosis definitely, but these are the key things you will be seeing. Then we come to protein, MSUD, ketoacidosis. So all the excess amino acids which are all there are going to get converted to keto acids. So ketosis, very, very classical. Hypoglycemia, absent gluconeogenesis and acidosis. So this is classical for MSUD. Organic acidemias, you can have all of these. Lactic acidosis, ketoacidosis and hypoglycemias. Urea cycle I just mentioned. Classical respiratory alkalosis with hyperammonemia. Very, very classical of urea cycle. The ammonias are in the thousands, so you can't miss it. Fatty acid oxidation defects, I was just mentioning ketones, absent ketones with hypoglycemia. Very, very classical of fatty acid oxidation defects. This is a beautiful flow sheet from Dr. Uma's article in Indian Journal of Pediatrics. Her article is very good. I think I have quoted it somewhere in my talk. It's an IJP recent in 2020. I'll show you. But it's a very good article. All of you should go through it for metabolic syndromes. So the diagnosis is based on acidosis, presence or absence of acidosis, or alkalosis, there is acid-base disorders, hyperammoniemias, hypoglycemias, and bone marrow suppression present or not. So if you start, so basically thing is just to mention that lactic acidosis criteria of more than 3 millimoles in a non-asphyxiated newborn. Hypoxia can cause a lot of lactic acidosis in a non-asphyxiated child, we have to do. So how do we go for this flow sheet? This is very nice. So you have a blood gas. You see metabolic acidosis. First, let's say you see respiratory alkalosis. pH is more than 7.45. PCO2 is like in the 20s. Okay. Then you definitely think of urea cycle disorder. You do an ammonia, it's going to be rooftop. Okay. Then you see only metabolic acidosis with an elevated anion gap, like something like 15 or something. Then immediately you do lactate. Really elevated lactate. Then you think of a carbohydrate disorder or mitochondrial disorders. If the lactate, we wouldn't say normal, not very highly elevated, you can do a urine ketones. Urine ketones negative, definitely think of a fatty acid oxidation defect. Urine ketones are present, then acidosis with a not a very elevated lactate with negative urine ketones, you think of organic acidemias or amino acid disorders. Hyperammonemia, that's the second criteria. With hyperammonemia, less than 24 hours, we have to remember this concept of TAN in preterm babies, especially in preterm neonates. There is called transient hyperammonemia of newborns. This is definitely a diagnosis of exclusion. They have very high ammonia levels, and all the other organic acidemias, fatty acids, and urea cycles, all of them have to be definitely ruled out before you think of a transient hyperammonemia. Why is it called transient? It does resolve, but takes a few months to resolve. Some kids have gone up to the level of dialysis, and then slowly protein feeds have been started, and then they've started tolerating. So always presenting within the last 24 hours, a preterm neonate, this should be at the back of your mind. Presenting later after 24 hours with absent acidosis, respiratory alkalosis, you should think of urea cycle disorder very, very importantly. And once you've thought of it with high ammonias and respiratory alkalosis, you based on the cycle and based on plasma citrulline levels, you can find out at which level the urea cycle disorder is happening, and you can do the specific enzymes. Okay, and other things you have to think of in the presence of acidosis and not respiratory alkalosis will be organic acidemias and fatty acid oxidation defects after 24 hours. Then based on hypoglycemia, because we have a lot of conditions with hypoglycemia, right? This it's not a very, but I just wanted to point out that absent ketone should go in the fatty acid oxidation line. Presence of ketones with acidosis, we can go into the other lines which we talked about, the initial acid-base disturbances. And finally, there are some metabolic disorders which show classical bone marrow suppression. All cell lines will be down, and some, like Gaucher's, they have classical inclusions in the bone marrow aspiration, which can point out the diagnosis for these storage conditions. Treatment. TABC for newborns. T is for temperature maintenance, very important, and ABC is actually airway breathing and circulation. They should be first provided with fluids. Lactate containing fluids should be avoided. We should be normal saline with dextrose. High quantity of dextrose is advised because it gives you more calories. You can use a central line also to get that in. The treatment is categorized into three. Removal of toxic metabolites, preventing catabolism, and cofactor therapy. Very important is removal of toxic metabolites. All the substrates which are toxic, they should be removed first. That is causing the symptoms or the encephalopathy for the child, so it should be removed immediately. So hyperammonemia, first NPO, start with fluids as mentioned earlier. Hyperammonemia, we have this cocktail benzoate phenyl acetate, which converts the ammonia to hippuric acid and excretes it in the urine. But you should, there's some new drug, N-carbyl glutamate, which is being used, which is experimental these days for hyperammonia. We should keep that in mind. Hemodialysis and CRRT, hemofiltration in the case of newborns. We have done hemofiltration for a lot of newborns for hyperammonemia. Acidosis correction, we all know, bicarb correction for neonates, slow bicarb correction, especially in the face of hyperammonemia because of cerebral edema. Prevent catabolism. So we're going to stop feeds, we're going to put the baby NPO, give only fluids till we get a diagnosis in 24-48 hours. So what should we do? We should prevent the catabolism of this patient. High sugars to maintain sugars in the 120s to 160s range with D20, even up to D20. You can also use insulin because it's an anabolic hormone, and a low dose, which can help. And lipids, low dose lipid infusion if it's not a fatty acid disorder, give some calories. Cofactors, very, very important. We know all of enzymes in these metabolic are cofactor dependent. So, cofactor, we know, I think all of you would have heard of pyridoxine dependent seizures. We've heard about carnitine is a very, very essential part for transportation of long chain fatty acids into the mitochondria. So these are very, very essential. Biotin as a part of biotidinease. So all these are essential cofactors which are specific for different disorders, which I'm very sure you'll hear a lot today in these different sessions. So this is to finally sum up. This was the first diagram I showed you. So the substrate is not converting to the product, right? So the substrate buildup is here. So what do? You have to decrease the substrate intake by the child using a special diet. This substrate, excess substrate, is getting converted by an enzyme to intermediate metabolites. These intermediate metabolites are causing a lot of symptoms in the baby. So how can you remove all these intermediate metabolites and the toxins produced by them? By hemodialysis, peritoneal dialysis, carnitine and other things. Then the product, product is not available, which might be an essential for the baby's development. You have to provide the deficient product by a special diet. Then the enzyme, we have a lot of enzyme replacement therapies, and now it's been replaced by stem cell transplantation for a lot of conditions. And finally, it's the gene therapy, where the gene which is the cause of all these problems can be replaced by a different gene so that the enzyme production and everything is normal. Okay? Any questions?
Thank you so much, madam, for one of the finest lectures of the day. It has definitely helped us to know more about the approach to neonates with inborn errors of metabolism. Now I request Dr. Kanagavalli madam and Dr. Sridevi madam to spell a few words about the session.
Good morning to all. First of all, I appreciate the topic of today's CME, the holistic approach to inborn errors of metabolism, because the present CBME, the competency-based CBME, this topic, it is going to give a foundation ideas on IEM upon which the students going to build the knowledge vertically in the clinical postings. Madam have just simplified the approaches on IEM, and all the charts pictorial representation was brilliant, ma'am. And you have integrated the biochemical lab findings with the inborn errors findings, the clinical findings. It was very useful. It was great to attend your session, madam. Thank you.
Good morning, everybody. First of all, I would like to congratulate Madam for this very simplified version. Her talk was, in fact, very, very simplified. And I think all the students would have benefited from the talk. Actually, this is a very complex subject, and as you know, we are spending one entire day on inborn errors of metabolism. So you must know the gravity of the topic. So Madam has spoken about the history. Any problem history taking is very important. Since the audience majority are students, I think you would have understood that a very detailed history is very important, followed by complete clinical examination, because that would help us not to miss any finding which would correlate further with the laboratory investigations. And finally, the treatment is, we have the help of many specialists. And newborn screening, we should insist on newborn screening in every hospital. Here yet in government hospitals, we have not yet started the panel of newborn screening. But still it is available in ICH, and we send all our samples to ICH. And there we do newborn screening. So the message of the day is not to miss any inborn error of metabolism, and newborn screening is a must. I once again thank our speaker, Dr. Shubha ma'am, for the excellent talk. Thank you, ma'am.
Thank you, ma'am. Now I request our medical superintendent, sir, Dr. Anbaragan, sir, Government Medical College and Hospital, THIRUVALLUR, to felicitate our chairpersons, Dr. Kanagavalli madam and Dr. Sridevi madam. For the next session, I would like to call upon Dr. K. Pramila Madam, one of the most mesmerizing speakers who will make the audience develop a passion towards a topic, to come and deliver the lecture on protocol-based diagnosis on inborn errors of metabolism. Dr. Pramila Ma'am is currently the professor and head of the Department of Biochemistry at Institute of Child Health and Hospital, Chennai. Madam has completed her MBBS from Chengalpattu Medical College and her post-graduation from Madras Medical College. Madam has more than 20 years of professional experience, and she is the first person to start tandem mass spectrometry based investigations in ICH lab for screening of inborn errors of metabolism, which was possible only because of her persistent efforts and strong determination. I also invite Dr. Kannan sir, professor and head of the Department of Physiology, Dr. Vijayalakshmi Madam, Head of the Department of Community Medicine, and Dr. Durgesh Nandini Madam, Head of the Department of General Medicine, to chair this session.
Good morning to all. I would like to congratulate the team, Dr. Prem Kumar and his wonderful team, even the students for conducting such a wonderful program. Maybe this is the first time in our state, like so many people coming together, and it's a holistic approach. I really appreciate you, Prem, for this wonderful program. And I'm happy to be part of this program. Thank you. Please, I need your attention. So here, take a look at this picture. So you can see two children here. The girl on the right was diagnosed of congenital hypothyroidism by newborn screening. And the boy on the left, who's crippled and is on the wheelchair, was not diagnosed. He was diagnosed only after he was crippled at the age of 12 years. And here in this picture, he is 14-year-old. And once the child is crippled, nothing can be done. So the child is physically and mentally crippled. So this implies the importance of newborn screening. So basic newborn screening panel. 7 disorders are included in the basic newborn screening panel. So the 7 disorders are, we have already seen congenital hypothyroidism. So what is the treatment for that? Once you diagnose in the early period, what is the treatment for that? Is only thyroxine. So the child born with hypothyroidism is normal at birth, like any other child. But once the child grows up, the child will develop physical disability and mental deterioration. So it's better. This is a part of prevention of mental retardation. We have a project going on, and this is congenital adrenal hyperplasia. And the other one is phenylketonuria, which Madam has elaborately spoken about, galactosemia, G6PD, and biotinidase, and cystic fibrosis. So these are the 7 disorders included in the basic newborn screening panel. So amino acid or time resolved or conventional fluorometry. So this is our newborn screening lab. We have a public-private partnership lab at ICH. So when do you suspect a case of IEM? So the mother brings the child with non-specific symptoms. Please, no talking. It should not be like a first MBBS class, right? You have come here to learn something, right? So biochemistry class, usually it's boring, right? What so many cycles, citric acid cycle, what all cycles, you know. So, but here you realize that citric acid cycle is a backbone for IEM. All the metabolic pathways, including the even branch chain amino acids, you think like so many names are there, but that is very important. So many disorders are there. So only when you're thorough with the basic fundamentals, the pathways, maybe not the names, you don't have to by heart everything. So you have to know the pathways, then only you'll be able to you diagnose the disorders. So clinical presentations. So as madam was telling, there's some block in the enzyme or a protein. So how do you identify? So the mother brings the child with non-specific symptoms. It can be poor feeding, drowsiness, lethargy, hypotonia, failure to thrive. Or the child, a 1-year child, like the mother will bring that there's no height control and hypotonia. And 1-year child not able to move around. So these are the pointers. So this side is cut now. Okay. Okay. So different ways of it. IEM can present in different ways. Whether neurological symptoms, with neurological symptoms, some of the disorders present with neurological symptoms, and some disorders with liver, involves liver, and dysmorphic phases like lysosomal storage disorders, and cardiac disorders like Pompe. Pompe is a hypotonic child, floppy baby. So these are the clinical pointers for specific IEM. What is cherry red spot? Have you heard of cherry red spot? So what is it because of? You have in a white background, you have a red spot. What is a white background? Due to the deposition of the abnormal lipid in the retinal cells, and the central fovea is devoid of retinal cells. So you can see the choroid plexus behind it. So that is the basis of that implies a neurological involvement. Name any two disorders where cherry red spot is there. Tay-Sachs and Niemann-Pick. Very good. Hello, welcome. So what is the first line of investigations? So basic investigations. Directly when you see a child suspected to have IEM, directly just because we have the technology improvement and you cannot directly do whole exome sequencing. So you have a protocol for that. So first you have to do the basic investigations. So what are the basic investigations is available everywhere. And before you refer any child, so you have to do the basic investigations. So complete blood count. You have to look for any decrease in the count. And the arterial blood gases, glucose, ammonia, lactate, liver function tests, urine ketones and reducing substances, serum uric acid. So we had a case a few months back where the uric acid was undetectable. So who is at fault? Is the lab at fault? So the child had come, suspected IEM child. So the technician reports that the uric acid is undetectable and it was repeated again, it was undetectable. And finally MRS was done. What is MRS? MRS, magnetic resonance spectroscopy, and where and other investigations were done. What is molybdenum cofactor deficiency? What are the molybdenum dependent enzymes? Why is uric acid low? Xanthin oxidase. And what are the other enzymes? Molybdenum dependent enzymes. Yes? So 3 enzymes are there. You should be knowing that. Okay? And then we did sulfite oxidase enzyme. So sulfite was elevated because the sulfite oxidase is also an enzyme which is molybdenum cofactor dependent. And those are the basic tests available everywhere. So, and then the second line investigations is tandem mass spectrometry. So we have seen in the basic newborn screening panel. So it's a dry blood spot sample. So there it is, with one spot we can do one test. Whereas with tandem mass spectrometry, with one drop of blood, we can identify so many disorders. Around 40 to 50 parameters can be done on a single drop of blood. So all these disorders can be identified: urea cycle, amino acids, fatty acid oxidation, organic acids. And for confirmation, we have to do gas chromatography, urine, organic acids. And these are all second line investigations. Orotic acid. Have you heard of orotic acid? What is orotic acid? In which pathway does it come? It's already there. In urea cycle disorder, to differentiate the two proximal urea cycle disorders. So enzyme assays. What is biotinidase? Biotin. What is biotin? It's a B complex vitamin. So the enzyme which releases biotin is called biotinidase. So even the child presents with refractory seizures, seborrheic dermatitis and alopecia. So when you identify this early, you can prevent complications, neurological complications. And so the administration of, what is the treatment here? Only high doses of biotin. So this should be identified early. And galactosemia, you are all aware of it. So what are the features of galactosemia? You can identify hepatomegaly is there, cataract is there, you can identify. So early identification and dietary management. So modification of diet helps. So this is a case with biotinidase deficiency child. The child was refractory to routine anticonvulsants, but not responding to anticonvulsants, and the child had loss of hair, alopecia and seborrheic dermatitis. So the biotinidase levels were very much low. The biotinidase levels were very much low. And this is the mutational analysis. there was a homozygous mutation and the child is on high dose biotin. So next is MRI. MRI narrows down the diagnosis. MRS is magnetic resonance spectroscopy. So here we can identify. So there be a lactate, elevation of lactate peak can be due to mitochondrial disorders. In maple syrup urine disease, you can see the leucine peak. And even last week we had the cerebral creatine deficiency, whereas the creatine was absent. Creatine peak was absent. And EEG also narrows down the diagnosis. And this is CSF amino acids. When do you do this? CSF had serum glycine levels. We look for in glycine encephalopathy. Glycine encephalopathy is also called non-ketotic hyperglycemia. So we have to differentiate it from ketotic hyperglycemia. What is ketotic hyperglycemia? Propionic acidemia, right? So next is pipacolic acid and plasma AASA. In which pathway does this come? In lysine pathway. So when you are narrowing down, you should know what are the about the. You should be thorough with the pathways. Very long chain fatty acids. So what is this? X-linked ALD. What is ALD? Adrenoleukodystrophy. So where very long chain fatty acids are elevated, why do you have to do ACTH and cortisol for this patient? Adrenoleukodystrophy. So the myelin, white matter is affected and adrenal cortex is affected. Why is adrenal cortex affected? Because very long chain fatty acids accumulate in the membranes. That becomes abnormal function, structure and function of the membranes. So that the receptor, please be attentive. It's not a UG class. Only those who are interested can sit here, the students at the back. And so why is, so the receptor present on the cell membrane of the adrenal cortical cells is not available. So ACTH receptor is not available here. So the ACTH level is elevated. And moreover, cholesterol forms an ester with the abnormal, elevated, very long chain fatty acids. So that cholesterol is not available for cortisol formation. You all know that cholesterol is a precursor for cortisol. So there is elevated ACTH and low cortisol. And this is the, so what is written here? Can you see in here? It is X-linked recessive. X-linked recessive is hemizygous, whereas autosomal recessive is homozygous. You should know that. Interpreting the genetic report. It's not no use ordering the genetic report without knowing how to interpret it. And there is, here you can see the child has dark pigmentation. What is the reason for dark pigmentation here? ACTH, MSH is also, what is MSH? Melanocyte stimulating hormone is in excess. So there is dark pigmentation of the palms. So this is the mutation analysis. There we have seen it is hemizygous. Here it is autosomal recessive is homozygous. Hypoglycemia workup. So you have to, when the child, the newborn presents with persistent hypoglycemia, it is not responding to treatment. What do? You have to do a simple test. Urine, what you do in the biochemistry practicals. What is it? Urine non-glucose reducing substances. Here it is, if it's present in galactosemia, this will be urine non-glucose reducing substance will be present positive, and you have to do enzyme assay for galactosemia. Here if the reducing substance is absent, look for ketones in the urine. So if it is negative, it is hypoketotic hypoglycemia. It's seen in various disorders, fatty acid oxidation disorders, ketogenesis disorders, or hyperinsulinism. So you have to differentiate these three disorders. How do you differentiate here? So hyperinsulinism, excess insulin inhibits the release of fatty acids. So there is no fatty acids. So here the low free fatty acids and low ketone bodies, because fatty acids are not broken down to acetyl CoA, and acetyl CoA cannot form ketone bodies. So both free fatty acids and ketone bodies are low. Whereas in ketogenic disorders, there is elevated free fatty acids but low total ketone bodies, because there is a block here. And in fatty acid disorders, fatty acid oxidation disorders, hypoketotic hypoglycemia with elevated acyl carnitins. So this is a differential diagnosis for hypoketotic hypoglycemia. So you have to rule out hyperinsulinism, fatty acid disorders and ketogenic disorders, and also exclude hypopituitarism. So what does it have with hypoglycemia, hypopituitarism?
We welcome our Dean, Dr. Telavadi Nadesanna. We are very proud to have her among our midst. Thank you, madam.
Welcome, madam. So exclude hypopituitarism. So you have to do, so low glucose values, you have to do provocative tests. What are the counter regulatory hormones? So you have to see whether the hormones, the counter regulatory hormones are elevated here. So you have to exclude glycogen storage disorders. So type 1 and type 3. So you have to measure hypoketotic hypoglycemia with hyperlactemia. It is type 1, glycogen storage disorder type 1. Here in type 3 it is low ketone bodies are elevated here and there is no lactic acid elevation. So that is how you differentiated type 1 and type 3. And this is administration of glucagon or epinephrine, since both glycogenolysis and gluconeogenesis are impaired. There is no elevation of, there is no hyperglycemic response to glucagon or epinephrine. Whereas in type 3, so what is the deficiency in type 3? The phosphorylase is normal, but the debranching enzyme is defective. So glucagon elicits glycemic response when glucagon is given after carbohydrate meal, and here it fails to respond after a fast. So these are the differentiating factors. So this is a case of type 1 GST with the type 3 GST. So urine metabolic screening. So these are the basic tests we do. So basic tests for urine metabolic screening. It's only a screening test, but it's not very sensitive. You cannot depend on it. Only when the child is acutely ill, you get positive values, and negative report does not rule out IEM. So this is our lab, tandem mass spectrometry metabolic screening lab, and ours is the state reference center for rare genetic disorders. And this is our team. Dr. Vinod and Dr. Ponmalar and others are there. So we are mainly concentrating on identifying the disorders of tandem mass spectrometry. So what are the disorders identified here? First we'll see the urea cycle disorders. So what is the type of specimen you need? Dry blood spot specimen. It's called Wortmann filter paper, 903 filter paper, or Guthrie's card. Who's Guthrie? Madam has already told about Guthrie. So since, yes, he is involved, he has done so much research into it, it's called Guthrie's card. So here, what is the difference between basic newborn screening? Only one test for one spot. But here, one spot, it is multiplexed. So many analytes can be identified on a single drop of blood. So proper collection is very important because it's transported from various places. So so blood collection, you say it's only a dry blood spot. Collection is really, you should have the patience, right? A single drop, there should not be another drop on it, and it should reach the other side of the filter paper. It should dry, it should be dried, allowed to dry properly, and should be transported. And you can see the smudged here during the rains, so we cannot analyze on this. And the poor patient, again we have to coordinate and get the fresh sample. So many pictures are here. So this is the card here, sample request form, and this is the report form. Hyperammonemia metabolic workup. A child with urea cycle disorder appears normal at birth, but only after the feeds, mother's feeds are given. After 48 to 72 hours, the child refuses feeds, vomiting, lethargy, and it can progress to seizures and deep coma, and it can mimic sepsis. So it's important to identify the child at this stage. So ammonia, analyzing ammonia, blood ammonia is crucial here. So if we do not analyze ammonia, and if we do not bring down the levels of ammonia by hemodialysis or peritoneal dialysis, the child will not survive, and we will also not know the cause of death, right? And we think it's sepsis, but we have to confirm the diagnosis so that for the second pregnancy we can plan the workup. So the ammonia levels were very much elevated. So prompt diagnosis is crucial here. So ammonia in blood, so there's a natural defense mechanism in the blood. So ammonium, hello madam, welcome madam.
It is my honor and pleasure to welcome our Dean, Omandurar Medical College. This college has been her brainchild. She has brought it down right from scratch. You can see this type of establishment being brought up by her. It is an exclusive thanks to her that this type of CME we are able to conduct it without any problem. So thanks to you, madam. Welcome, madam.
Welcome to Arasi madam. Thank you madam. It's really like we are really, the students are really fortunate to have such a building here. Okay, we'll go back. So normally at physiological pH, you all know that ammonia is toxic. So most of the ammonia is present in the form of ammonium ion, which cannot cross the blood-brain barrier, or it cannot permeate the cell membrane. Whereas ammonia diffuses into the cell. 99% is present in the ammonium form, and only 1% is present in the form of ammonia. So what are the natural buffers? The body tries to protect itself. So by increasing the amount of this buffering amino acids. So when ammonia levels are elevated, so alpha Kg is depleted. Why is alpha Kg depleted? Because the ammonia is, glutamate levels and glutamine levels are elevated. Glutamate carries one ammonium ion, and glutamine carries two. So this way it tries to buffer, and at the expense, at what expense? The alpha Kg is depleted, and so there is secondary energy deficit. And so this condition should be identified as early as possible, right? So the consequences, what are the consequences if it is not identified early? So there's depletion of alpha Kg in the brain, which leads to secondary energy deficit, and increased glutamate. Increased glutamate is, what is glutamate? It is a neuroexcitatory transmitter, and glutamine causes osmotic effect, swelling of the brain cells, So the triad of urea cycle disorder is hyperammonemia, acute encephalopathy, and respiratory alkalosis. Why is there respiratory alkalosis? So elevated glutamine, we have seen that it is osmotically active. It causes cerebral edema and stimulates the respiratory center and causes respiratory alkalosis. So this is a sample collection. Sample collection, the ammonia should be collected and it should be collected and immediately processed. It should be transported, kept in ice. And why is it immediately processed? Because the red cells and platelets can release ammonia. It's no use doing later. This is the method being done in our lab and these are the normal reference values. So once a child is identified, newborn, when ammonia levels are very high, so we cannot wait longer for the further investigations and so we have to reduce the levels by doing peritoneal dialysis or hemodialysis. So this is the basic investigations, first line of investigations we do. And here, there is in urea cycle disorders, there is hyperammonemia and respiratory alkalosis. So this pathway. So proximal urea cycle disorders. What are the two proximal urea cycle disorders? CPS1 deficiency and OTC deficiency. So here in both the conditions, citrulline levels are low, but we cannot identify, but TMS is not that sensitive to identify citrulline. So how do you differentiate this? We have to do orotic acid. Orotic acid, why is orotic acid formed here? When there is a block here, carbamyl phosphate levels are elevated in the mitochondria which spills into the cytoplasm and which enters the which pathway? Pyrimidine pathway and orotic acid is formed. So you can differentiate this. When there is a block here, orotic levels are elevated. When there is a block here, higher up, there is no orotic acid. This is how you can differentiate. And further, finally, you have to do the genetic testing for confirmation. So distal urea cycle disorders. So this is a report, tandem mass spectrometry report of a child with citrullinemia. So citrulline levels are elevated. So when is citrulline levels elevated? What is the next enzyme here? ASA. What is ASA? First years might be knowing. So when there is a block here, it's called citrulline levels are very much elevated. Here you can see the reference range. It's more than 100 times elevation. So it can be due to citrullinemia type 1 or type 2. Type 1 is due to the enzyme defect. Type 2 is due to the transporter, arginine transporter defect here. The next one is, what is this? Arginosuccinate lyase. Here citrulline and arginosuccinate both are elevated here and this can be identified by tandem mass spectrometry. And we use the secondary markers, the ratios for sensitivity and specificity and to avoid false positive cases. And this is a case of argininemia, the last enzyme where the arginine levels are very much elevated. Triple H syndrome. What is triple H? One H is hyperammonemia. We are all were discussing. What is the other two H? Where is the defect here? So defect is the transport of ornithine into the mitochondria. So when there is a defect here, ornithine levels are elevated in the blood. What is it called? Hyperornithinemia. And then when ornithine cannot combine with carbamyl phosphate, so lysine combines with this to form homocitrulline. Normally citrulline is formed, but here because ornithine is not available, it combines with lysine to form homocitrulline. So homocitrulline levels are elevated. So these are the three H. So hyperammonemia, hyperornithinemia and homocitrullinemia. So those are the disorders, amino acid disorders we have seen. What are the disorders we have seen? Proximal urea cycle disorders, and the two disorders can be differentiated by doing orotic acid. And next is a citrullinemia. It can be one. Type 1 can be due to the enzyme defect. Type 2 is due to the defect in transport of aspartate from the mitochondria. And the next one is ASL deficiency, where citrulline and ASA are elevated. And the last one is arginase deficiency. The other one is triple H syndrome. So amino acid disorders. So madam was already mentioning about this. So the enzyme defect here is phenylalanine hydroxylase, and the cofactor here is tetrahydrobiopterin. So here when this enzyme is defective, phenylalanine levels are very much elevated, and this is neurotoxic, and this takes another path. The pathway is diverted to form alternate intermediates, and the mousy odor is due to the accumulation of phenyl acetate. So this should be diagnosed yearly, and the child will have hypopigmentation. The reason for that is tyrosine is not formed and melanin is not formed, right? And it should be diagnosed yearly. And proper dietary management, with proper dietary management, the child can lead a near normal life. We can prevent mental retardation. So this is the basic, the urine metabolic screening, ferrichloride test was positive for this child, and this child is on follow-up. The child comes with his grandmother. The grandmother was anxiously waiting for the TMS report. The earlier, when the child was diagnosed, it was phenylalanine is more than 1000. It was 1500, and the next time it was 1200. And after 3 months they came, and they were on strict dietary management, and dietitian plays a very important role here. And my grandmother was really waiting, and when the report came as 800, my grandmother was very happy. Actually, it should be maintained at lower levels until 5 years, until the brain development. So dietary management. This is a case of maple syrup urine disease. The child, this is a newborn days baby. The child was normal at birth, and slowly the child developed feeding problems, vomiting, seizures, and muscular rigidity. You can see here. And the urine metabolic screening, DNPH test was positive. What is DNPH? Dinitrophenylhydrazine test was positive. So this is answered by, this is not specific for this is answered by keto group and aldehyde group. So it forms a yellow precipitate. Where does the keto group, an MRI was suggestive of MSUD. So here there's a block here, branch chain keto acid dehydrogenase. So there is elevated leucine, isoleucine and valine. And what is allo-isoleucine? So allo-isoleucine is formed from isoleucine, and this stays longer, and this is a better marker for identifying MSUD. And the characteristic smell is due to a compound called sotalol. It is formed from cyclization of isoleucine. So this is the report of the child. So you can see here what are branch chain amino acids: leucine, isoleucine and valine. So values are very much elevated here. And leucine, the tandem spectrometry cannot differentiate leucine and isoleucine because it identifies based on mass to charge ratio. Both contain 6 carbons. So they are eluted together here. And alanine is, when leucine levels are elevated, alanine is decreased. What could be the reason for that? Because alanine is needed for gluconeogenesis. So alanine decreases when leucine is elevated. So this ratio is taken here, leucine by alanine ratio. So this is a GCMS. So child is in follow-up, and during the COVID time, so we have a tie-up with the ORDI, Organization of Rare Diseases of India. So where they supply, when we register online, they supply the dietary supplement free of cost. And here the mother has sent a WhatsApp message. We received powder. That was during the COVID time where they could not come here. So these are the children diagnosed in the newborn period. So it's important to do, so even sepsis workup is done, but still we have to do ammonia. ammonia, any workup, ammonia, IAM workup, ammonia should be the primary investigation. Without doing that, it's no use doing ABG, finding out whether there is metabolic acidosis with anion gap or respiratory alkalosis or ketone bodies. So ammonia plays a primary role here. And I think any lab which is doing IAM should establish the facility of having the ammonia, because it cannot be transported to a far off place. So it should be done immediately, and no use transporting it in ice and after sending it in the morning, and when the lab receives the sample at the evening, and all the ammonia would have been released from the cells, and we get high values, and with that it's no use interpreting. And I'll discuss only a few cases, please. Okay. So tyrosinemia type 1, tyrosine. So we have discussed about phenylalanine to tyrosine. So tyrosine is metabolized. What is the end products of tyrosine? Tyrosine is both glucogenic and ketogenic, right? So the metabolic defect is in the last step, FAA to fumarate and acetoacetate. When there is a block here, these two accumulate, FAA and MAA. These two are very toxic. They're toxic to the liver and kidney. So it is called hepatorenal tyrosinemia. Tyrosinemia type 1 is the last step is affected. This is also called hepatorenal tyrosinemia, because these two intermediates are highly toxic, which cause toxicity to liver and kidney. And so succinyl acetone is an important marker here. So succinyl acetone is formed from MAA and FAA. So this inhibits the first enzyme in heme synthesis, ALA dehydratase. So it can mimic acute intermittent porphyria. So the child may come with peripheral neuritis. So the intermediates, the FAA and MAA, are toxic to the renal proximal tubules. Renal proximal tubules. So the glomerulus is normal, it filters everything, but reabsorption is not there. So everything is lost. Amino acids are lost, glucose is lost. Blood glucose may be normal, but urine glucose is present. Amino acids are lost, and phosphate is lost. Because phosphate is lost, there is vitamin D resistant rickets. Because of phosphaturia, the child may come with signs and symptoms of rickets. So the child may present with cholestatic jaundice, abdominal distension, and even the clotting PT, APTT may be elevated. And alpha fetoprotein, we have to look for alpha fetoprotein, because these two intermediates are alkylating agents which can cause mutation and cancer. So this is a report of a child with tyrosinemia type 1 or hepatorenal tyrosinemia. So here you can see tyrosine levels are elevated and succinyl acetone too is elevated. So how is succinyl acetone formed? From MAA and FAA, which inhibits the first enzyme in heme synthesis. So this can mimic acute intermittent porphyria. A case of homocystinuria. So the child would have morphonoid features, high arched palate, subluxation of lens, and long arms. So here the urine metabolic screening, cyanide nitroprusside test was positive, and sulfur test was positive because sulfhydryl groups. The homocysteine contains sulfhydryl groups. So homocystinuria type 1, the classic type, is due to CBS deficiency. So here when there is a block here, both homocysteine and methionine are elevated. So here TMS can identify only methionine. When methionine is elevated, we have to look for homocysteine too. So this you will be knowing. So skeletal abnormalities. So dislocation, how do you differentiate this from Marfan's? Marfan's is dislocation of lens is upwards, whereas here it's downwards. What is the reason for the downward dislocation of lens? Because disruption of the cystine. Cystine is here, this is the homocystine is converted to cystine here. When there's a block here, cystine levels are very low. So disruption of the cystine-rich zonular fibers that hold the lens in place. So because of cystine depletion, and there is downward displacement of the lens. And bilateral dislocation of lens inferiorly increases the curvature of lens, which leads to myopia. So this is about homocystinuria. And glycine encephalopathy, the other name for it is non-ketotic hyperglycinemia. So deficiency of glycine cleavage pathway. So TMS glycine is elevated, but what is the investigation we have to do? The ratio CSF to serum glycine ratio should be done for this. So because the increase of glycine in CSF is disproportionately high when compared to serum. So fatty acid oxidation disorders. So here you have non-ketotic hypoglycemia, low ketones, and so this is CPT type 1. Type 1, what is the finding here? Carnitine, this is the carnitine pathway. So carnitine cannot be converted to acyl carnitine, the shuttle. So carnitine levels are elevated in CPT1, whereas in CPT2, acyl carnitine levels are elevated. Medium chain acyl CoA dehydrate, this is the commonest disorder in fatty acid oxidation. So the child presented with hyperammonemia. What could be the reason for hyperammonemia here? The fatty acid oxidation disorder. Any idea? So here, during starvation, fatty acids are utilized. When there's a block here, medium chain acyl CoA dehydrogenase, the fatty acids, the activated fatty acids, acyl CoA accumulates, and this is converted to acyl carnitine because CoA is trapped here. CoA is needed by all cells for which reaction? Pyruvate to acetyl CoA. So CoA, this acyl CoA is converted to acyl carnitine, which is increased in the blood, and this acyl carnitine inhibits the urea cycle enzyme and causes hyperammonemia. So these acyl carnitines, they enter the omega oxidation pathway and they are converted to dicarboxylates. So there is dicarboxylic aciduria, hyperammonemia. On TMS there is acyl carnitine elevation and there is hypoketotic hypoglycemia. These are the features of medium chain acyl CoA dehydrogenase deficiency. So this is the report of a child with MCAD. Organic acidemias. So there is metabolic acidosis. So this is a case of propionic acidemia. A child with propionic acidemia where propionic acid, propionyl CoA contains how many carbons? So you have the number of carbons is very important here, three carbons. So C3 acyl carnitine is elevated here. So when there is a block here, propionyl CoA is elevated, C3 is elevated. And so this presents with metabolic acidosis with anion gap because of the accumulation of toxic intermediates, and lactic acidosis because propionyl CoA inhibits the PDH. So, and then ketoacidosis, anemia, neutropenia and thrombocytopenia because this propionic acid inhibits the bone marrow stem cells, hyperglycinemia because propionyl-CoA inhibits the glycine breakdown. And because of inhibition of other mitochondrial enzymes, there is hypoglycemia and hyperammonemia. These are the features of propionic acidemia. So, multiple carboxylase deficiency. What is multiple carboxylase deficiency? So, what is biotin? What are the functions of biotin? 4 carboxylases. What are the 4 carboxylases? You can see here. Propionyl. What is PCC? ACC, MCC and PC. So, these are the 4 carboxylase, biotin dependent carboxylases. And tandem mass spectrometry, how do you identify this? There is elevation of C5OH and C3 carnitine. But it's difficult for a beginner. In one day, you cannot learn all the interpretation. This is only for you to be aware of this. So, these sort of things. Okay. C3 and C5OH. Do you understand? It looks like Greek and Latin, right? Do you understand? No. That's why you're feeling sleepy, right? C3. Okay, I'm not going into the detail of it. Okay, in 1 hour I cannot teach you everything. So, multiple carboxylase deficiency and glutaric acidemia. So, these are the cases we have seen in ICH. Glutaric acidemia. So, there's a block in the pathway here. So, glutaryl-CoA accumulates. So, this is a pathway of tryptophan, lysine and hydroxylysine. Now, you all know how difficult biochemistry is, right? So, this is and this can be identified by MRI. MRI shows battering appearance. You learn what battering appearance is. I am not going into the detail of it. So, here glutaric acidemia, what is it? What is elevated? C5DC. What is C5DC is elevated. So, how do you interpret that? So, you have to know how many carbons glutaryl-CoA has. Glutaryl-CoA, glutaric acid is 5 carbon dicarboxylic acid. So, C5DC is elevated. That's the language of IEM, right? TMS interpretation. We don't talk about the names of it. C3 is elevated, C5 is elevated, C5OH. So, you have to become familiar with it with time. This is another case of isovaleric acidemia. A newborn was diagnosed. So, this is branch chain amino acid. There is a block in the enzyme here where isovaleryl-CoA is elevated. So, how many carbons does this contain? 5 carbons. So, 5 carbon is elevated here. So, these are the features of isovaleric acidemia. So, this child is on treatment now and follow up. The similar thing like the child we saw with MSUD, this child during the COVID period, so it was getting the nutritional supplement. So, you can see the child sitting here with the supplement. So, what are the precautions to be observed while collecting samples? This is the last slide. Collecting before any specific treatment is given. So, samples should be collected before treatment is started, and samples for ammonia and lactate should be transported in ice and tested immediately. And detailed drug history is important. And suppose sodium valproate therapy might increase the ammonia level. So, drug history should be taken into account while collecting samples. Thank you. I just want to know how many of you could understand this. Can I ask you any questions? No. C3 elevation, C3 acyl carnitine elevation. So, what is the disorder? You should know the propionyl-CoA, right? It has got 3 carbons. C3 is elevated. I have not gone into the detail. It will be really confusing. This is only the basics, the cases what we have seen for you to be aware of it, right? If you don't understand also, it's okay. It's 1 hour, you cannot understand everything. So just for the classification, okay, ammonia and how important is ammonia, okay, and then urea cycle disorders, then fatty acid oxidation disorders, um, what else? Amino acid disorders and organic acidemias. So that is the take-home messages by TMS. TMS is on a dried blood sample, and all these disorders can be done on that.
Thank you, ma'am. Thank you for the so simplified and approach to the diagnosis. Actually, we have put a cases pictures, so I hope undergraduates will not forget these cycles.
I request Dr. Mahesh Harishchandra Hampe sir, Senior Consultant of Medgenome Labs, Bengaluru, to felicitate Dr. Pramila Madam, Professor and HOD, Department of Biochemistry, Institute of Child Health, Chennai. I request Dr. Durgesh Nandini ma'am from the Department of General Medicine to share the reviews of the session.
Good morning. Respected Dean Madam, my favorite and beloved Omandurar Dean Madam. Welcome you, Madam. And first of all, I thank Department of Biochemistry, especially Sir Prem Sir, for giving me this opportunity, because I know Sir for a long time from Chengalpattu itself. His involvement and dedication in every work, wherever he is working. And the topic itself is excellent, and in the topic choose பண்ணதுக்கு it is my appreciation, because நம்ம UG daysல usually I'll skip this topic. If choice is there, first skip பண்றது inborn errors of metabolism. Openly I'm speaking, and இந்த topic இவ்ளோ interesting பண்றதுக்கு hats off to the team. And coming to Madam Pramila Madam, I didn't have a chance to meet Madam, but I heard a lot from her. She only established the analysis in ICH first, it seems, in Tamilnadu, and she covered all the topics. Like initially she started with metabolic disorders, all the 7 disorders, which includes the patterns of presentations and the clinical pointers towards the IEM. And she highlighted about the refractory seizures in neonates. If it is not controlled with the usual anti-seizural activity, we should go suspect biotin deficiency also, she highlighted. So many points. Each slide has so many important points, and the whole topic itself is you'll have 10 to 15 short notes, like tandem mass spectrometry she told, and highlighted about the MRI, importance of MRI in neonatal screening. Usually in MRI neonatal screening, we'll skip callosal agenesis. So she, every small points she highlighted, and I learned a lot today actually. So I am so honored to be to chair this session, sir. Thank you so much.
I request our RMO, Dr. Rajkumar sir, to felicitate the chairpersons, Dr. Vijayalakshmi ma'am and Dr. Durgesh Nandini ma'am.
I request all the team leaders of the poster presentations to come out of the lecture hall. Only the team leaders of the poster presentations. Thank you.
அரியவற்றுள் எல்லாம் அரிதே பெரியாரை பேணி தமராக்கொளல் என்ற வள்ளுவனின் வாக்கினை மனதில் நினைத்து மொழியில் மூத்தவளாய் செவிக்கு இனியவளாய் உலகெங்கும் பறந்திருக்கும் செம்மொழியாம் தமிழ்த்தாய்க்கு என் முதற்கண் வணக்கத்தை தெரிவித்து இந்த கட்டேனா 23 விழாவிற்கு வருகை தந்திருக்கும் மருத்துவ சான்றோர்கள், ஆன்றோர்கள் மற்றும் எதிர்கால மருத்துவ வித்தகராய் திகழவிருக்கும் எனது மூத்தோர் மற்றும் சக நண்பர்கள் அனைவரையும் வருக வருக என அன்போடு வரவேற்கின்றோம். இவ்விழாவின் முதல் நிகழ்வாக தாய்மொழியாம் தமிழுக்கு வந்தனம் கூறி தமிழ்த்தாய் வாழ்த்தினை பாட மாணவ செல்விகளை இம்மேடைக்கு அழைக்கிறோம்.
I request everyone to rise for the Tamilthai Varthu.
திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மனக்குள் இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிலமை திரும்பியந்து செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
தமிழுக்கும் தங்களுக்கும் நன்றி கூறி சிறப்பு விருந்தினர்களை குத்துவிளக்கு ஏற்ற அன்போடு அழைக்கின்றோம்.
I request the dignitaries to come and occupy the dais.
மங்களமாய் மாண்புகள் சிறக்க மத்தாப்பு ஒளியாய் வாழ்வின் வெளிச்சமாய் இறை ஒளியாய் என்றும் இருள் நீக்கும் ஒளியாய் அறிவு தீபமாய் ஆன்றோர் வழிநடியை கடைபிடிக்கும் நிகழ்வின் முதல் நிலையாய் தற்பொழுது குத்துவிளக்கு ஏற்றல் நிகழ்வு.
A good professor inspires hope, ignites the imagination, and instills a love of learning. I take immense pleasure in introducing our professor and head of the Department of Biochemistry, Dr. K.S. Prem Kumar sir, who is an accomplished and distinguished member of our academic community with a wealth of experience, expertise, and knowledge in the field of biochemistry. Sir plays a crucial role in shaping the direction and vision of the college and the department. Sir is also a Senate member of the Tamilnadu DR.MGR University. We feel extremely privileged to have such a person with so much professionalism, dedication, and unwavering commitment to patient care. We now welcome Dr. Prem Kumar sir to present the welcome address.
தமிழ் அன்னைக்கு முதல் வணக்கம், என் தாய் தந்தைக்கு இரண்டாம் வணக்கம். A very pleasant morning to all. A true leader guides others to success, ensures everyone performs to their best. They are humble but not rude, kind but not weak, humble but not timid. These are the qualities shown by our guest of honor, Dean, Government Omandurar Medical College, Dr. R.C. Srivatsan. Madam, it's our pleasure and it's an honor having you among us, madam. Thank you, madam. Great leaders set out to make a difference. It's never about the role, always about the goal. I'm proud to welcome our Dean FAC, Dr. Tilagavati, who always has a goal in her mind. Welcome, madam. Education is the most powerful weapon which can be used to change the world. A person who believes in education is our beloved medical superintendent, Dr. Anbadagan sir. Sir, I welcome you, sir. A true friend, philosopher and guide is my beloved classmate, our RMO, whom I am very proud to welcome to the CME. I would also like to extend a very warm welcome to all the eminent speakers of the CME Catena 23. They have spent their time to travel to this place, which is quite far, but still they want to impart their knowledge, their experience among us. I would like to thank all the eminent speakers for having come so far to impart their knowledge. Thank you all. I will also like to welcome our judges. Right from the beginning of my career till now, they have been, Dr. Meera, Dr. Srinivasan have been a very good support. So, it's my pleasure welcoming them. I also extend a hearty welcome to all the chairpersons who have come to chair the various sessions to be held today. A very warm welcome to all the HODs and faculties from our college and other colleges, whom I already know them for quite some time. I welcome you all to this CME, and it is our pleasure to welcome all the students from various colleges, not just from our colleges. Welcome to the CME. So, it is you who are going to get benefited from this CME. So, hope you'll get a take-home message from this CME. All the best. God bless. Thank you.
Thank you so much, sir, for your energetic words. Now I take immense pleasure to introduce you the titan of our THIRUVALLUR Medical College and Hospital, the man of motivation and energy, the person being the soul to our hospital since its beginning. It's none other than our RMO, Dr. Rajkumar sir. We welcome you, sir, to embrace us with a few words of enthusiasm.
Thank you for the kind words. Good morning, everyone. Good morning, madam. Good morning, Dean FAC, madam. My colleagues, friends, and dear students, the star-studded panelists of speakers today. So, it's a pleasure to welcome you all to our hospital and college in our series of CMEs of our various departments. So, being a pediatrician, I want to share a couple of things regarding IEMs. So, IEM is under-recognized and under-reported now with the evolved screening and more awareness. We are diagnosing more IEMs in our clinical practice at our hospital. So, it's our duty to be aware of the diagnosis when nothing else, as the previous speakers told, nothing, when we have an intractable seizure or any other cause, we have to be aware, because the quality of life is very poor and the family is going to face a big burden with any IEM child. So we have quite a few patients in our hospital and private practice with IEMs. So as it's our duty to be aware of the diagnosis so that the quality of life, however much long the child lives, the quality of life is better and the family's burden is, with the correct advice and correct dietary advice and correct management, the family's burden can be reduced. And this, for the students, at this stage it might seem IEMs, Madam told Greek and Latin, at least you can learn all the metabolism, carbohydrate, amino acid, and other various metabolism. If you are thorough with that, it is very easy to understand the IEM and diagnosis. Thank you, madam.
Thank you, sir, for the wonderful speech. Now I take immense pleasure to welcome our medical superintendent, professor, and HOD of Department of General Surgery, Dr. Anbalagan, sir, who has undergone rigorous training and has demonstrated exceptional skills and knowledge in the field of surgery. We are fortunate to have you join us, sir. Your presence here will help us progress in our journey manifold. We welcome you, sir, to address the gathering.
Thank you. Respected Dean, Professor Dr. K. Tilagavati, Madam, our beloved pillar and founder, Dean, and leader who guided and developed this institution to this level. And most respected Professor Dr. R.S. Srivatsan, Honorable Dean, Government of Andhra Medical College, our dynamic and energetic RMO, Dr. Rajkumar sir, and other dignitaries on the dais and off the dais, all the faculties of our institution and expert eminent faculties from other institution, and my dear postgraduates and undergraduate students assembled here. Good morning to you all. First of all, I wish to congratulate our Department of Biochemistry led by Professor Dr. K.S. Prem Kumar sir for having conducted this wonderful CME. It's a very useful CME on holistic approach to inborn errors of metabolism by both offline as well as online mode. Although it is a very rare disease, incidence is 1 in 2,500 live births, but it can present at any age. Therefore, awareness about the disease among the practicing physicians is very important to decrease the morbidity and increase the physical quality of life of these patients. Hence, I request the PGs and UGs to utilize the CME to its fullest extent. Happy learning. Finally, I wish the CME a great success. Thanks for the opportunity.
Thank you, sir. We are delighted to welcome our Dean FAC, Dr. Tilagavati Madam, who has nurtured this academic event by her reckless guidance and encouragement, without which this event wouldn't have been what it is today. When the going gets tough, the tough gets going. Likewise, Madam, we have seen you being calm and managing even the toughest situations in a very cool manner, which has served to be a great inspiration to every one of us. Now we request you, Madam, to deliver the presidential address.
Thank you for your kind words, respected Dean Madam, respected MS Sir, RMO Sir, and HOD Biochemistry, dear faculties, UGs, PGs, and UGs. A very good morning to all. So today we have this inborn errors of metabolism, CME. So in the incidence of this inborn errors of metabolism is about 1 in 800 to 1 in 2000. As Sir said, it is 1 in 2500. In this geographical area where the consanguineous marriage is high, the chances of this inborn errors of metabolism is high. So there is, even though there are higher institution which is diagnosing inborn errors of metabolism, here in this geographical area, this is very important. And to create awareness about the inborn errors of metabolism, SAR has conducted this CME. So congratulations for choosing this topic, Dr. Prem Kumar sir. Next thing, if you know the principles of inborn error of metabolism, 90% of the biochemistry is over. So, in morning lande evening varaikum endha topics la neenga pathingena about 90% of the, I think I am correct. Yes, madam. So 90% of the biochemistry is over when you listen to these topics. So for UGs and PGs, the topic sessions given by Dr. Subha, Dr. Pramila Madam, Dr. Mahesh, Dr. Chelian Sir, Dr. Sumita and Uma Mageshwari, they are the distinguished speakers in this topic. I congratulate Madam, make use of their expertise. Then I also want to put one question to the UGs and PGs. Do you know which is the powerhouse of a cell? Mitochondria. So which organ has highest concentration of mitochondria? Do you know? Which organ has highest concentration of mitochondria? Anyone? So one simple clue, where cardiomyopathy, in inborn errors of metabolism, the cardiomyopathy is more common because of this reason. So the heart is the organ which has the highest concentration of mitochondria, where most of the cardiomyopathies occurs in inborn errors of metabolism. So research is an important thing. So yesterday also we have Department of Microbiology has presented 2 proposals in university, and with also the Department of Physiology and ourselves we have presented given proposal to ICMR STS projects. So I would welcome all the departments to submit the proposals. You get ready of the proposals by today itself, by today onwards. This topic, this IEM topic, you can give, you can co-author, not co-author, with biochemistry department and pediatrics department, they can start a proposal on IEM activities, because this area is more prone for this IEM because of the consanguineous marriage. So I welcome more proposals from the pre and paraclinical departments in combination with the clinical departments. A combined project will be more helpful in addressing the day-to-day problems. So once again, wish you all the success to the department and for the CME. Thank you.
Thank you so much, Madam. We feel privileged to welcome our honorable guest for today, Dr. Arasi Srivatsan Madam, who has made us accomplish the CME with her relentless support and highest level of inspiration. Madam has been a great pillar of strength in every way. She has also been like an unsung nightingale for our college and hospital, which gained fame under her leadership. There are no words to describe your commendable contribution to this budding institution, Madam. Now we request you to share your words of wisdom with us, Madam.
Thanks for the kind words, Ma. Very nice and beautiful words. Hope I am standing as an example for that. And it is indeed a great pleasure to be here, not as a dean as Omandurar, dean of Omandurar, but as a past dean of this THIRUVALLUR Medical College. Literally, that Omandurar echoes into my ears as Greek and Latin, definitely. But anyway, I have to hold the post and I have come here. And I should thank all the dignitaries on the dais for inviting me as a chief guest here. And I thank Dean FAC Dr. Tilagavati. But one difference I see now in her face is she has become a bit serious. Probably she has become a dean. So I can see the seriousness in her face. And I thank Dr. Prem Kumar. He is like, if he charges at a bullseye, I know he will hit the bullseye. He is such a nice person. When he takes the task, he hits the bullseye. So I congratulate you, Dr. Prem Kumar, for conducting this beautiful CME Catena 23. And definitely our medical superintendent, Dr. Anbalagan, is really an asset for our medical college. And though he is very silent, he knows all the work what he is doing. And no words to express my gratitude to Rajkumar. He has been once again he has been as a team and a pillar to this hospital. And I thank you, Rajkumar, for inviting me here. And definitely the CME is going to be very beautiful because of the speakers who have come here. Dr. Subha Karthikeyan, Dr. Parimala, Dr. Magesh Harichandra, Dr. Cherian, Dr. Sumita Danda, and Dr. Uma Mageshwari. All these speakers definitely are going to make this CME a wonderful CME and impart a great knowledge to you. And definitely you will benefit out of it. And this is not the first CME of our hospital. And you colorful students, I know definitely the moment I went there, the first function which I took over was the graduation function. You were definitely in my mind when I was participating in that graduation function. And my humble request is, please call me for your graduation function. And I will definitely attend after 3 years. Probably I'll be only 63 then. So don't worry, I'll be still energetic. I'll come here. And I also always tell my dreams will come true. I know I will definitely participate in your graduation ceremony, which I would definitely enrich. It will enrich my attitude also. So please, I look forward for that, though it is 3 years later. And the CME has only one speaker I have heard, Dr. Pramila. I know her because she has worked with my brother. And she is definitely a very nice speaker, and your topic was very good, ma'am. And really, I also could recollect what I have read in biochemistry. Such was the recollection I could make. And one more word about my friend, Dr. Meera. She was a professor of biochemistry and also vice principal of Kilpauk Medical College. And we both were pilot to the then Chief Minister, Dr. MGR. There was a parade in 1983 for the college day in our hospital in NCC, and we both were pilots doing the slow march for Dr. MGR, and we could always recollect those incidences, and it was a great honor for him and for us also. We could never forget that. And thanks for calling me for the CME, and I wish the CME a great success, and thank you again.
Thank you so much, madam. You have always been a great inspiration and highest level of strength to our college. Now, heading to the felicitations. Now, I invite Dr. K.S. Premkumar sir, Head of the Department of Biochemistry, to felicitate our guest of honor for today, Dr. Arasi Srivatsan ma'am, Dean, Government Medical College, Omandurar. I also request sir to felicitate our Dean FAC, Dr. Tilakavati Madam, Government Medical College and Hospital, Thiruvallur. I request sir to felicitate our Dean FAC, Dr. Tilakavati Madam, Government Medical College and Hospital, Thiruvallur. I request sir to felicitate our Medical Superintendent, Dr. Anbaragan sir. I also request sir to felicitate our RMO sir, Dr. Rajkumar sir. Thank you, sir. Now I invite Dr. Arasi Srivatsan ma'am to felicitate our judges for the poster making competition. Dr. Meera madam, HOD of Biochemistry at Institute of Child Health and Hospital, Chennai. I request Madam to felicitate Dr. Srinivasan Sir, Associate Professor, Department of Pediatrics, Government Keelpok Medical College. Now I request Ma'am to felicitate our speakers, Dr. Mahesh Harish Chandra Hampe Sir, Senior Consultant of MedGenome Lab, Bengaluru. Dr. Cherian Sir, Professor of Radiology from our Government Medical College, THIRUVALLUR. Thank you so much, ma'am. Now I invite Dr. Tilakavati Madam to felicitate the various faculties of our college who have been instrumental in making the CME happen today. Dr. Kannan Sir, Head of the Department of Physiology. Dr. Jagannathan Sir, Associate Professor, Department of Pathology. Dr. Vijayaraj Sir, Department of Pediatrics. Dr. Jagadish Kumar Sir, Department of Pediatrics. Dr. Prabhu Shankar Sir, Dr. Pungoday Ma'am, ARMO, Dr. Tamil Selvi Madam, ARMO, Dr. Jayachandran Sir, Assistant Professor, Department of Pathology. Dr. Ratnavel Kumaran Sir, Assistant Professor, Department of Physiology. Now we felicitate the faculties of our Department of Biochemistry, Dr. Prem Kumar Sir, Head of the Department. Dr. Lavanya Devi Madam, Associate Professor. Dr. Menaka Devi Madam, Assistant Professor. Dr. Saraswati Madam, Assistant Professor. Dr. Chandra Devi Madam, Assistant Professor. Dr. Shantini Madam, Assistant Professor. Dr. Shivapriya Madam, Assistant Professor. Dr. Lata Madam, Assistant Professor. Now we felicitate our postgraduates, Dr. Rajashankar Sir, Dr. Jayabharati Madam, Dr. Harita Agnes Madam, Postgraduate, Department of Biochemistry. Dr. Rajashankar Sir, Postgraduate, Department of Biochemistry. Now we felicitate our senior lab technicians, Dr. Balaganeshan Sir, Valarmati Ma'am, now we felicitate the office staff, Ganesh Kumar Sir, Yoganandam Sir, we felicitate Dr. Ganesh Kumar Sir. Yoganandam Sir, Solomon Raj Sir, Santosh Kumar Sir, Keshavamurthy Sir, Inbaraman Sir, we felicitate Dr. S. Vijayaraj sir. Now we felicitate Solomon Raj sir. Now we felicitate Dr. S. Vijayaraj sir, Department of Pediatrics. Thank you, madam.
Gratitude springs from a heart brimming with the feeling of thanksgiving and gratifies both the receiver and the giver. An important part of any event is thanksgiving, as it provides an opportunity to express gratitude and appreciation to the individuals who have contributed to the success. Now I call upon Dr. Lavanya Devi Ma'am, Associate Professor, Department of Biochemistry, to present the vote of thanks.
A very good morning to one and all. Thanksgiving is a time of togetherness and gratitude. I'm very happy to deliver this Thanksgiving on behalf of our department. We thank wholeheartedly our respected Dean Madam and beloved Dean Madam, Dr. R.C. Srivatsan Madam, for being our backbone and continuously supporting us to bringing up this program to this live session. I sincerely thank our Dean Madam, Dr. Tilakavati, who has been continuously being in support with us after our Dean Madam's absence too, and mentally supporting us in creating each and every step. I thank our MSO sir and our RMO sir for being our major pillars in bringing up this program. I thank judges, Dr. Meera Madam and Dr. Srinivasan sir for being here for doing this poster presentation judgment. I thank our respected chairpersons, respected speakers for being here in the CME program. I thank the professors, associate professors, assistant professors, and students from our college and from various other colleges for taking such a time to come to this place and making the CME a great success. I thank the students of our college of 21 and 22 batches, MBBS students, who have been the major pillars in bringing up this program with so much of colors. I thank the office assistants, PWD workers, electrical and water supply department for uninterrupted supply, and last but not the least, the Crystal team who have been maintaining everything clean and clean. I thank the Almighty for providing us this opportunity and bringing the CME to great success. Thank you one and all.
Thank you, ma'am.
நிகழ்வின் இறுதியாக தேசிய கீதம், அனைவரும் எழுந்து நிற்கும். Attention please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा तव शुभ नामे जाहे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
வாழ்க பாரதம், வளர்க தமிழ், வாழ்க வையகம். ஜெய் ஹிந்த்.
Bharati. It will
Heading on to our next session, with great pleasure, now we invite Dr. Mahesh Harishchandra Hampe, Senior Consultant of MedGenome Labs, Bengaluru, to deliver his Noble Lecture. Sir has completed his MBBS at Rural Medical College, Ahmednagar, DNB in National Board of Examinations, Delhi, and MD Biochemistry in Nashik. Sir had been Assistant Professor in VM Government Medical College, Solapur, Consultant Biochemist in Preventine Life Care in Mumbai Lab. He had been the Director in LifeCell International, Chennai, serving at present as Senior Clinical Chemist in MedGenome Labs, Bengaluru. He has been awarded the Young Scientist Award from Ambicon in 2011 at KAPV College, Trichy. He had been the university rank holder in MD Biochemistry. He had been the technical and lead assessor empaneled to NABL, India. He was awarded the Young Achiever Award in Biochemistry in Ambicon 2015.
He is also a life member in AMBI. Now, we welcome Dr. Mahesh Harishchandra Hampe sir to deliver the lecture on techniques and advances in diagnosing inborn errors of metabolism. I invite Dr. Kannan sir, Professor and HOD, Department of Physiology, and Dr. Padmalata ma'am, HOD of Obstetrics and Gynecology, Government Medical College, THIRUVALLUR, to chair this session.
For forward and backward. This is for forward, and this is for back side. Back. And what is the? Okay, yeah, correct. And what is the indicator? Okay. Fine. Yeah. I understand. I'm standing in between your lunch and the. Okay, fine. So, I'm Dr. Mahesh. I'm the senior consultant at MedGenome. My purpose, actually, I'm really thankful for Dr. Prem and his team for organizing such a wonderful seminar, offering me this platform. I really thank Dr. Pramila ma'am for sharing the session with me and giving the kind referral. At the same time, if I could be able to initiate any single brain in this auditorium to initiate IEM lab, my very purpose coming down all the way from Bangalore to here will be served. So I'm planning to make it more lively session. Previous two sessions have made my job quite easy. Probably this session belongs to the core biochemist, okay, who are more interested into biochemical genetics. Okay, you might have heard, probably this is one of the new terminology you might have came across. Okay, I'm working in this field of biochemical genetics since last 12 and a half years. And I'm really thankful to God that I got the privilege to work in the mass spec lab in the early career of my post-MD. So I'm here, my sole purpose is to share whatever experience I got through this tenure of biochemical genetics I have been through. So the objective of my session is very straightforward. Okay, I understand probably this may not be applicable, or my session may not be applicable to those non-technical team members, or probably you are sitting all in front, you don't have back besides, probably whatever I will tell may not be absorbed into the brain, but you have to be absorptive, because this session would be very informative. You will get, I guarantee you, you will get some knowledge which may probably initiate the thought that okay, definitely we should give some aspect of clinical domain into this IEM screening. Somebody from the previous speaker said that IEM are very rare and we could only help to salvage the situation. That is not the situation. I'll give an example, say galactosemia. Only stopping galactose, which is actually milk is a blessing for a child, right? But it becomes toxin actually if we feed the baby, galactosemic baby with milk. Okay, same is the case with biotinidase deficiency. So if simple supplement of biotin changes the complete scenario. Okay, so same is the case with congenital hypothyroidism, right? Okay, so my objective is very simple here. I need to enlist those lab investigations which are prevailing currently. Most of them have been covered already in the two sessions. the common basic screening conditions, as previously ma'am has said, there's G6PD, biotinidase, PKU, IRT, 17-OHP, okay. And specific diagnostic test, I will touch upon the expanded screening panel, which are currently actually required, and tandem mass spectrometry in some detail, because I love this instrument, and probably if down the line, if you will feel, okay, you need some support setting up a tandem mass spec lab, okay, I would be there at the tip of your finger to call me and take any help for in this matter. And challenges in screening and diagnosing IEM, don't say challenges of finances, okay. See, I'm telling you, I'm not against immunization, but I'm telling you, it's a human cause, it's a noble cause. But the cost of congenital hypothyroidism screening of whole population of India is half of the oral polio vaccination. So you can imagine, because the cost benefit ratio of any program does matter, okay. Here, if we screen 400-500 cases and I can save one baby getting mentally retarded, the purpose is served, okay. We have already covered it. The IEMs are either deficiency of enzyme, cofactor, or the associated conditions. So it usually happens in infants, and those irreversible damage happens and all those things. I need not to go into the details, but taking an example, just Subha ma'am in the morning said, if we have one reaction as A to B, which forms C and D eventually as products, if the blockage is there in the reaction of A to B, there is accumulation of A and production of absolutely new products as E and F. Just like phenylalanine not converted into tyrosine. So tyrosine is the product. From tyrosine we are having epinephrine, norepinephrine, melanin, so many useful products. Catecholamines, they are not formed, which are C and D. So instead of that we have phenylactate, phenylactate, phenylpyruvate, which are E and F, and deficiency of C and D, obviously. And all manifestations of phenylketonuria are either due to accumulation of E and F, means toxic metabolites, or deficiency of tyrosine, right? So this is how the fingerprint. I tell you, in metabolic picture, whenever we study metabolism, okay, we call it as metabolic signature or metabolic fingerprint. I will give an example. Say, for example, diabetes, polyuria, polydipsia, polyphasia, decrease insulin, high glucose levels. This is a metabolic signature of IDDM. Same is the signature of PKU. Okay. So, categories we have already covered. I don't want to go into the details of this. This is the man. Anybody knowing? Okay, we have talked about this person. Okay. I tell you my story. When my son got diagnosed with adamantinoma, I started reading everything about adamantinoma because I want to save my child. Okay, same thing happened with this kid, with this very microbiologist. He was a researcher. He was not a physician. Okay, but when he saw his niece getting diagnosed with PKU, started looking into diagnostic modalities and managing this elevated phenylalanine level, because phenylpyruvate is neurotoxic. So controlling phenylalanine level and managing phenylalanine level was the challenge at that time, and tube dilution method was prevailing at that time. He started that use of Wattman 903 filter paper collection, and this is what is the blessing nowadays. Okay, in one single drop of the baby's blood, we can diagnose so many conditions, right? So it is because of this fellow, he got so many inhibition. Dr. Besnan, he was a very famous pediatrician in USA. He kept on pricking him. This is nonsense. You should not do this. This is not acceptable in US. He started this in 1960 and 1965-66 when Bickel, Dr. Bickel from Germany, he invited him and started accepting it. Then worldwide, the people started believing that this is also possible. Okay, and with the advent of new ELISA platforms using this dried blood spot, see, Watman 903 filter paper, why this only filter paper is used? Because it has got a uniform spreading. Okay, when drop of blood is spread, okay, you imagine the spread of the blood is based on what? RBC constituent, means hematocrit, and what, how much liquid it has. Okay, one circle of that prefix circle accumulate almost 60 to 70 microliter of blood, and that became a blessing for us actually. So previously we were doing only one blood sample and one test, or one analysis and one test. Now it is possible that we can do multiple tests out of single blood spot. Okay, that is spot, and that is one punch we take. Okay, so previously there was a challenge how many conditions we should think of. Okay, some countries were adopting 3 conditions, 4 conditions, 7 conditions, 10 conditions. There was no uniformity. But recently in 2007, ACMG, American College of Medical Genetics, they have started initiating the program of uniform screening panel for IEM screening. Okay, I'm telling you, these disorders are selected based on only 2 things. Whether the natural history of this disease is known or not, okay, and whether the treatment outcome, without treatment and with treatment, whether there is significant difference or not. And those disorders are considered into the core panel or secondary panel, which are of sense. And third condition is whether the diagnostic test is accurate, specific and sensitive or not. And fourth thing, affordable, good quality treatment is available or not. So 4 or 5 conditions, that those criteria are used by that expert panel of ACMG, American College of Medical Genetics. If you have mobiles right now, go and type acmg.org. This is a beautiful website. You can learn all the disorders. You have, as ma'am has said previously, ACT algorithms of all the disorders are possible. Second, if you have mobile right now, you type any name of the disorder and type gene reviews. Okay, you have updated PubMed reviews of that particular disorder. Say type phenylketonuria or PKU space gene space reviews. You will get the beautiful information of PKU right from the clinical features, metabolic markers, genetic information, proband analysis, management, the prenatal screening, everything. So these 2 websites. And third website, you just type metagene.de. This is again a beautiful website wherein you type the disorder, you will get all the list of markers based on the platforms. Say if I want to do HPLC, what all markers I will get which are elevated or decreased. Say for example, one lecturer has said creatinine biosynthetic defect. So you will have increased gonadotropin level, decreased creatine level, right? So supplementation of creatine is the treatment. So you will have that gonadotropin level elevated, fine. So that metabolic signature is available in that website, metagene.de. So such websites are of importance for a beginner, I'm telling you, which give you information, holistic information. Today's CME is holistic approach. So we need to have that holistic websites. See, I'm telling you, all these disorders are well studied, too much studied. Okay, what we need to do is whether are there any consensus guidelines available and consensus websites where all the information, where scientific communities have contributed to that website and enriched that database of the disorder. Okay. So these are routine techniques you might be knowing. I'll just ask, say for example, I'm having a case of, I'm just asking you, randomly you tell me, if a case of hypoketotic hypoglycemia is there. Okay, ketone bodies are low, glucose is low. What are those conditions? In the morning we have studied so many things. Any guesses? Fatty acid oxidation disorder, right? Okay. So, say for example, when reducing sugars are positive in the blood, in the urine sample, but blood glucose levels are normal, or urine glucose is normal or negative. Which is the condition? Galactosemia. So these are the logics. Say madam has said uric acid, undetectable uric acid levels. Okay. Molybdenum cofactor deficiency, right? Okay. So these say 5 amino level inequality. Delta amino level inequality we call it. Okay. It is one of the surrogate marker for type 1 tyrosine. Right? Okay. Wherein we can have AFP elevated also. We can have succinylactone elevated also. We can have tyrosine elevated or normal also. We can have this hepatic and renal manifestations. This is called signature, metabolic signature or metabolic fingerprint of that particular disorder. I hope you got the point. So we have so many simple tests available. I don't go into qualitative tests, which madam has said, say some non-specific tests like Benedict, DNPH, ferric chloride, okay, which are nowadays obsolete. Okay, my today's session is on metabolomics. So I will switch directly to this. Previously, this is the trend going on. Previously, it was PKU screening in the 1960s. Then came ELISA, advent of ELISA, so many antigen antibody complexes we could decipher, and then we have automation, then we have tandem mass in around 1980 and 90, which exploited in the diagnostic segment. See, I am telling you tandem mass, if somebody will say installation of tandem mass are more in pharma department, but not in medical labs. Okay, why? Because tandem mass started in 1960, but they are used in the lab in 1990 almost. You got it? So this is lethargy from the medical domain people like us. Okay, I will take the onus. Okay, and this is why we are lagging behind giving personalized medicine. We are all here for personalized medicine, I am telling you. Approach which is personal to that particular patient. Okay, it is, see, for a pediatrician it is not easy. Say I am sitting in a pediatric room or an OPD, okay, I'm used to sepsis. Okay, patients are coming, I have fever, malaise and all those things, malaria, typhoid and all those things I am comfortable with, because I have seen so many cases. Suddenly such case comes which is complicated one, CRP negative, all C3, C4 normal, fever is not there, other things are not there, neurological manifestation, so many other complications. So I am not comfortable treating this case. Same is, yeah, it's a fact. So where the role of biochemist comes, or a senior faculties comes, or such seminars come, wherein we extrapolate our knowledge, okay, and do the differential diagnosis, share the opinion, share the clinical details with the lab, and we sought the help of metabolic or biochemical genetics lab, right? So this is how LCMS, GCMS, so many other platforms, state-of-the-art platforms came into the picture, right? So I told you, recommended uniform screening panel, recommended by 2007 by ACMG. Okay, these are the disorders. You count it, there are around 29 disorders in, this is in 2007 I am telling you, and 25 disorders, 29 plus 25. Okay, and most of the disorders, they are on tandem mass spectrometry, except the 7 conditions which I told, which ma'am and previous speakers are told, 7 conditions plus hemoglobinopathies. Rest all are possible on tandem mass spectrometry in 2007. Okay. And later on, these 7 conditions are added into this panel based on the fact that the treatments are now available, tests are now available. We can give the treatment outcome is better for these disorders, and they are slowly added. In 2009 they thought, okay, we should add SCID, but because adenosine and deoxyadenosine can be calculated or can be done in the tandem mass spectrometry same run. Critical congenital heart diseases are possible either by genetic or by the biochemical analysis. Pompe disease is possible. Okay, fine. Then MPS 1 and Pompe. See, I am telling you, MPS and Pompe, this is another segment of utilization or exploitation of tandem mass spectrometry. These are considered as lysosomal storage disorder. Fine. Okay. X-linked ALD, wherein previous speaker told C26LPC, very long chain fatty acids. C26LPC, and the ratio of that 26 to 24 and 22, okay, is nothing but XALD screening, okay, and that is the only X-linked recessive disorder, correct? And spinomuscular atrophy and MPS 2 is recent addition to this RUSP panel, fine. So, coming to our first mode of investigation is tandem mass, okay. So, I am telling you, this is very simple platform, simple technology, only constraint is cost, okay. But if you can set up an LCMS lab, it is not so difficult, because LCMS contains nothing but LC and MS. And if you have tandem MS, then LC and 2 MS are included into that, okay. So, advantage of this LCMS is that you can have so many applications possible on this. Say for example, ma'am has said ki amino acid and acyl carnitine profile. Okay. Nowadays you can't imagine this analysis of amino acids and acyl carnitine is done in 100% births in US and Australia. Can you believe it? This is because they have adopted RUSP. Correct? But we have not. It is still on a payment basis or played by the private customers like us. Fine. It costs around maybe around 1,500 to 3,000 rupees per patient. Okay. The cost of LCMS comes around starts with 1.7 crore and ends with highest model of around maybe 3.2 or 3.3 crore. So you can think of this. So if you have returns, right? Okay, you can start with HPLC. Okay, you get the knowledge of HPLC. HPLC doesn't cost too much. It is hardly 25 lakh rupees. If you have a detector, HPLC, maybe binary or quaternary pump and a detector, it is not so costly. If you will go for a PDA detector, okay, that is a photodiode array, which covers so much of wavelengths, so it is little bit costly, maybe around 15 lakhs separately, but within 30 lakh rupees you will get the HPLC system, right? GCMS is even cheaper, right? It is the whole setup comes around 45 lakh, 40 to 50 lakh rupees for a beginner. Why I am telling the cost? Because you have got the inhibition, right? And you have got a technical question of technical expertise. No, that's not a challenge. It's very simple. We biochemists, okay, I'm addressing this forum as if I'm dealing with clinicians and I'm dealing with technologists. Okay, this lecture may not be good for first MBBS students. I'm extremely sorry. Fine, but I came here to impart and share my knowledge, and I will do that. Fine. So this amino acid and acyl carnitine profile, MAM acid C3 means what? Propionic acidemia. It is also methylmalonic acidemia. Why? Because there is a phenomenon called phase 1 biotransformation and phase 2 biotransformation reaction. Have you heard of this? I will tell you simple example. Carnitine is a conjugation. Okay. If any acid accumulates in the blood, say propionic acid, propionyl CoA carboxylase deficiency, propionic acid is elevated. Propionic acid is not converted into D-methylmalonyl CoA, right? This is the reaction. So propionyl CoA is accumulated, it forms propionic acid. This is acid. Acid forms, decreases the pH, metabolic acidosis happens, secondary hyperammonemia happens, right? This is the cycle, this is the fingerprint. So this propionic acid, body wants to get rid of. So how it will be get rid of? It will either be phase 1 biotransformation to form 3-hydroxypropionic acid. And this propionic acid attaches with oxaloacetic acid to, instead of acetyl CoA and oxaloacetic. This is the first step, na? Citric acid cycle. Acetyl CoA plus oxaloacetic acid forms citric acid. Instead of that, it will form methyl citric acid because acetyl is not there, propionic is there, correct? So methyl citric acid is the fingerprint of propionic acid. This forms in urine. 3-hydroxypropionic acid. Hydroxylation reaction is the commonest first or phase 1 biotransformation reaction. Hydroxylation. Okay. Because propionic acid is not water soluble. We have to make it hydrolyze so that it can be excreted in urine. Same is the case with that propionic acid has to be conjugated with carnitine to form propionyl carnitine. Then it will be excreted in the urine and that it elevates in the blood sample also. So that is why we are exploiting LCMS to calculate this propionyl carnitine. Same way, propionyl glycine is excreted in the urine sample. And this is pathognomonic of propionic acidemia. What is pathognomonic? Anybody? So KF ring is pathognomonic of Wilson's disease. What is that pathognomonic means? Yeah. 3-hydroxyglutaric acid is pathognomonic of glutaric acidemia type 1. It's very specific. It is specific to that single disorder. Succinylacetone is pathognomonic of tyrosinemia type 1. So these are rules, signature rules. Okay, say some in radiology, sir is there. Okay, there are some rules, some images or some, say, butterfly pattern in the brain is type 1 glutaric acidemia, correct? That way. Okay, these are, what? I really don't know. I am very poor at radiology. Okay, I only know, as ma'am has said, MRS. Okay, whenever when somebody asks, sir, I am suspecting non-ketotic hyperglycemia, I say, sir, do you have MRS? Have you seen glycine levels? If somebody says, okay, sir, I have sent urine sample for N-acetyl aspartic acid to you, just check with Canavan syndrome, Canavan disease. I say, okay, sir, do you have MRS? Have you checked the NAAS peak in the MRS or not? Okay, so this is how the interdisciplinary approach and signature comes into the picture. Okay, so I told you that amino acid and acyl carnitine profile is commonest application. This is revolution in RUSP. I am telling you, because of this platform, we could diagnose almost close to 55, 56 disorder in one single blood spot, one single run. Fine. There are so many methods, derivitization, non-derivitization, so many commercial labs commercial kits are available now. Okay, I'll tell you the company name of this LCMS. If somebody is interested, I don't bother if somebody don't want to listen it. There, Shimadzu is there, cheapest one. If you want to go ahead, you have Waters or Agilent. If you want to again go ahead, there is Thermo Fisher. If you want to again go ahead, go for Perkin-Elmer. Okay, so AB Sciax is there. So many platforms are there. I just revealing. I don't know whether any commercial. It has nothing to do with commercial part. Huh? I'm not carrying anybody's logo or publicizing these platforms. Okay, I'm absolutely neutral. And there are so many kits are also available. Say for example, if somebody is interested to develop this amino acid acyl carnitine profile, it is based on actually selection. Say for example, mam acid ki orotic acid, we have to do this estimation separately. But if glutamine is added in the existing amino acids, most of the kits give 12 to 13 amino acids, right, in the kit. If you add glutamine, that becomes more specific for urea cycle disorder, right? Okay, so say for example, if I will have a case of OTC, just imagine a scenario. Ornithine transcarbamylase deficiency. What is the fingerprint of that? It is low citrulline, hyperammonemia, right? And orotic acid elevated, right? So if I will have glutamine elevated, citrulline low, and maybe arginosuccinic acid or arginine, they are also low. Okay, I will have a fingerprint to say that this is definitely a proximal OTC or any proximal urea cycle defects, right? Okay, so it is based on, say for example, somebody is interested in distinguishing citrullinemia, whether it is type 1, type 2 or arginosuccinic acidemia. So I will include arginosuccinic acid into the list of amino acids. So I don't want to sponsor somebody, but some kits are available which includes arginosuccinic acid, which includes C26 LPC, so that X-linked ALD is also addressed. Some kits include lysine, and lysine is also one of the marker for what? Pyruvate decarboxylase deficiency, right? Okay, so some kits are giving adenosine and deoxyadenosine also, which takes care of SCID, severe combined immunodeficiency syndrome, right? So these are some of the additions, amendment in the same existing kit. Okay, some kits are adding succinylestone also. So most of the time I'm telling you, tyrosinemia type 1, it is a misnomer actually. It is not tyrosinemia. Tyrosine is never elevated. Most of the time it is normal. I have seen type 1 tyrosinemia with normal tyrosine levels, mostly in the ranging between 250, 300, not crossing 400 even, right? But succinylestone is most of the time elevated. I ask them, they say, okay sir, I have done AFP, it is coming high. I suspecting hepatocellular carcinoma. I said yes. Okay, it is type 1, right? Okay, so this is how things are becoming more good as far as the comprehensive panel addressing is concerned. Okay, we have additional parameters. Based on that, we do vendor evaluation or vendor selection, correct? And in-house development, it has got advantages also. Say for example, I can add any number of amino acids in that mixture of internal standard. What is internal standard, I will let you know later in this session. Okay, if somebody is not interested in tandem mass or GCMS or LCMS, they can leave. Okay, I will keep on doing this for next 20 minutes. Okay. So this is what is interesting. LCMS, LCMSMS. Okay, which one is good? Anybody guess? One is single mass spec and second is having two mass spec. So, ek se bhale do. Somebody says na in Hindi. Okay, so first mass spec. See, I am telling you, LC means it has got a column. When I injecting a sample inside, okay, LC separates it and it gives to MS. Okay, then MS, what it does? MS is tuned for a precursor ion. Precursor ion. Say for example, phenylalanine is a precursor. So I know the structure of phenylalanine, right? So it identifies phenylalanine. Then it goes to the Q2, means collision cell, wherein phenylalanine, if it is going inside, it is broken down. And the pattern of its fragments are very characteristic. See, fragment of phenylalanines means, what is that called? 3 or 4 or 5 types of fragments it might be doing. Say for example this, if I will break, it will create distinct characteristic fingerprinting fragments. So I know which fragment, how many fragments are possible, which fragments are most specific for phenylalanine. Now all these fragments go to second MS, and amongst those 5-6 fragments, one fragment identifies that it is definitely phenylalanine, and second fragment identifies how many fragments, how many original phenylalanine molecules are there. You got it? So that is one. First is called qualified ion, and second one is called quantified ion. So it becomes very specific to calculate phenylalanine. I won't measure anything else. I will measure only phenylalanine. Fine. So that is the advantage of having 2 MS. So that collision cell between 2 mass analyzer. This is called triple quadruple, because 3 things are there. Mass analyzer means MS1, collision cell is MS second quadruple, and MS2 is third quadruple. That way. Got it? This is the principle of LCMS. I told you already. Say homocysteine, if I want to measure, what I will do, homocysteine is a carbon molecule, right? It's an organic compound. What I will do, in that homocysteine, one carbon is there, I will label it. Label it means I will use a radioactive molecule. Say for example, carbon, we are using carbon dating. What we use? Labeled carbon, na? Radioactive carbon we use. Correct? Or N, instead of N7, what we use? N8 or somebody. Right? It is a heavy molecule than the original present in the normal sample. Okay? So what I will do, in that blood sample which I punch, it contains what? Homocysteine. What I will add into that is internal standard, which is homocysteine but labeled. So what I have in the reaction mixture is the homocysteine from the sample, patient sample, and the internal standard from my kit, which is also homocysteine but heavy homocysteine. You can see original homocysteine is 136.1 m/z and labeled homocysteine is 140.1. Their retention is also same, but I can identify them. Which one is patient's homocysteine and which one is labeled homocysteine. Okay, now I know the concentration of labeled homocysteine. So I know 3 things. I know the concentration A, B, C, D. If we know 3 things, 4th thing can be easily calculated, right? So I know the concentration of internal standard. I know the fragment of internal standard. I will get the response of internal standard. Response, concentration and response. There is a, say in optical density, what we do? Glucose concentration. Tape 5 glucose concentration we take and take the OD at the end of reaction, correct? So we get a plot. Same here. We get a calibration curve and we get a value of the sample. Homocysteine it contains. This is the simple, very simple principle of LCMS. It's not something very, what is that called? Rocket science, right? Can you see this? Say, if I will add an internal standard of say 4 nanomole. So internal standard contains the dotted circles. Okay, and those solid blocks are the analytes of interest. Say homocysteine. Okay, so I will make a mixture of it, incubate it, clean it and give it to LCMS. I will get the responses. Area of the labeled and area of the non-labeled. Non-labeled means patient. So, and concentration of the labeled is already known because known only added. Correct? So, getting these 3 values, division, I will get the concentration of the analyte of interest. Simple. That is called isotope dilution mass spectrometry. IDMS. You might have heard this word number of times, right? MD biochemist people. Correct, na? IDMS. Okay, say for MCQ is there. What is that called? Uric acid. Reference method is isotope dilution mass spectrometry. Okay, because most of the calibrators, controls, standards, they are prepared or traceable to the reference method, and most of the reference methods are mass spec based method, right? Okay. Same here. Okay, specificity. Most of the time in methyl malonic acid is not possible to be done in the LCMS. Why? Because interference with succinic acid is there. Ma'am has said leucine and isoleucine cannot be isolated or cannot be distinguished. Even hydroxyproline complicate the scenario because all three compounds are having same M by Z, right? Or C5DC or C6OH, same, right? Malonic acid, C3DC and C4OH means hydroxybutyl carnitine, same. So that this is a limit of the LCMS. So we have to get rid of this by doing specificity analysis. Okay. Second application, plasma amino acids. Why it is required? This is second tier testing. When you go to the ACMG website, you will get to know that you cannot confirm one disorder unless and until you confirm it on other platform. Say for example, give an example of hemoglobinopathies. Okay. Say if I will get sickle cell trait on HPLC and if I will get same sickle cell trait on electrophoresis, it is more or less confirmed, right? Because sickle peak coming at specific retention time, okay, doesn't mean that it is sickle only, because in that window there are almost 70 to 80 sickle variants available, because that window is named after a common variant appearing in that position. Got it? Say for example HBA, but most of the time it is not HBA, it is commonest variant. HBA is there, but in that position, because HB variants are more than 1000. Do you know that? 1000 variants are eluting in that 5-6 minute window. Okay, there are only 7 or 8 windows, right? So in one window, there are possibilities that hundreds of variants are there. So that's why second platform analysis is a recommendation from ACMG. So same thing, if I am getting an MSUD confirmation, I want to do plasma amino acids. Alloisoleucine is the pathognomonic of MSUD. Okay, if alloisoleucine is there, everything is normal, I will say it is MSUD. Got it? Because, fine. And all these comprehensive amino acids are helping us actually for confirmation of other disorders also. Fine. Okay. Say for example, same method I will exploit it for urine also. Right. Say for example, some disorders are not possible in blood. Lysonuric protein intolerance. I have to check lysinuria. Lysine levels are never elevated. Lysine levels are decreased only. Hyperammonemia is there all the time. So I have to check urine sample. Heart nerve disease, I have to check urine for ornithine or tryptophan, right? So I have to go for that particular platform. So selection of platform is based on your pathology, right? So amino acids, you need to have clinical indications. You cannot do straight away all the samples exported for the plasma amino acid, not necessary. Say for example, organic acidemia. What information will you get from amino acid profile? No, zero. Say, I will take an example of fatty acid oxidation, MCAD. MCAD is commonest one. Okay. Do you know MCAD, one publication has happened. We also contributed to that MCAD study, wherein one institute called Mayo Medical Lab, okay, they have done the study of postmortem study of the cardiac sample. They have collected the left atrial sample of postmortem babies and they have found very surprising results. Almost 7% of cases are having MCAD, sudden infant death syndrome. That was their inclusion criteria. So MCAD, baby dying during fasting, during sleeping. is very common in FAOD, fatty acid oxidation, because the moment hypoglycemia happens, it usually happens in fasting only. Fasting, hypoglycemia and death is very common. Very, very common. They get to be fed every time. Right? And that too glucose only. Correct? So you have to utilize the analytical technique. Okay? Plasma or urine, what to be done. Calibration and quantitation. This is one of the simplest thing which is required whenever you are dealing with any method development in HPLC or LCMS. Okay. Calibration mixture, NIST. Do you know NIST? Anybody knowing NIST? National Institute of Science and Technology. Okay. I told you about that fragment. Okay. That fragment pattern is a database. I have a team of almost more than 100 people working in bioinformatics only. And they are working on this fragment pattern only. So you imagine the science has evolved too much, wherein they are doing a data analysis of complete metabolome of the humans. Say, you know, Human Genome Project, wherein they are doing the NGS of all the population and checking all the variants possible. Okay, based on that, some commercial kits are also coming nowadays. Ki diabetes, whether metformin will be useful for this patient or not. Bigonides are good or not. Sulfonylurea will be good or not for this patient. Based on what? Genetic workup. Okay, because they say or they claim that this genetic information is directly translating into pharmacokinetic and pharmacodynamic behavior of those drugs. Okay, same way here. Okay, we are doing metabolomic study, untargeted metabolomics of, say, if I will say one patient of MSUD will come to me, I will do the complete metabolome. Complete metabolome means its fingerprint of that particular patient. I will have all branch and amino acid elevated, leucine, isoleucine, valine. I will have all keto acids elevated. Keto-isocaproic acid, keto-isovaleric acid, methyl-isovaleric acid, so many intermediate alpha keto acids, right? So that becomes a fingerprint of that MSUD. They want to check the fingerprint and check the surrogate marker, new surrogate marker. Say, for example, new disorder has come. We have one study in tumors wherein this condition, Duchenne muscular dystrophy, DMD, they are having even dystrophin gene analysis. Instead of that, if we can run that sample for untargeted analysis, say 20 or 30 patients, we may get a different metabolic marker altogether on LCMS. And we will utilize that information that DMD, usually these 5 or 6 markers are usually elevated in the patient as compared to normal patient. That is called untargeted metabolomic analysis. Okay, this is one of the application of LCMS, right? I'm telling you. So that markers can be utilized, exploited for the management, diagnosis and management algorithm or follow-up monitoring of that particular disease, right? Okay. So this NIST is nothing but bioinformatics tool. Recalibration, I don't want to go into the details of this. This lab requirement itself is a big chapter. Okay, it will take another, for me it will take 2 or 3 hours to explain you how the calibration, validation and verification of HPLC or LCMS works. Okay. Use of IS, I have told you, internal standard. Okay. For all the amino acids in LCMS, which we are doing 12 or 13 amino acids and acyl carnitine. Okay, maybe 12 or 13 acyl carnitines are there. Internal standards we have to add so that we can take care of the technical inaccuracy. And we have denominator every time, right? Denominator we have internal standard. So we can calculate the corresponding, say for example, I want to diagnose a case of glutaric acidemia. So C5DC internal standard I will add into that, right? So C5DC sample divided by C5DC internal standard and their responses I will have after MSMS analysis. I will get the C5DC value, right? Okay, or C5OH, fine. So this selection is dependent on, is required for the accuracy purpose. Okay, performance check, we have to periodically check. Say for example, entrance standards, I usually purchase, I don't know ma'am about you, but we purchase it from Cambridge Isotope Laboratory, and they really appreciated us that you are few of the labs who are utilizing all these resources available for the scientific community. Okay, so I usually believe that we should initiate utilizing those resources which are already been available at our disposal. Fine. Validation matrix, calculated parameters. Say some parameters are not directly possible. Say C8, so C8 is to 1. So C10 is to 1. So we have to calculate some of the things. So pre-analytical variables, some old samples are coming. I will give a simple example. Say G6PD, on day 4, day 5, the value comes low. We falsely give positive for G6PD. We have to take care of that, right? Right. So those pre-analytical ways, some IV drugs are given. So some liver dysfunction is there. Say some phenylalanine levels are elevated. Okay, when we do tandem mass spectrometry, phenylalanine, tyrosine both are elevated. So the ratio is important, right? Phenylalanine to tyrosine ratio. As ma'am has said, it should be more than 2 to be called specific, to called PKU. Okay, so there where free analytical variables come into picture. Blood transfusions are given. So we usually get C16OH elevated. If valproate is given, C5 is usually elevated. Sorry, C8 is elevated. Fine. If amoxicillin or ampicillin is given, then C5 is elevated. That way. So reference ranges, Dr. Vinod from ICH, he is doing one presentation, right? By the end of this month, na? July, yeah, July. 30th of this month, na? Yeah. So do attend that, okay? Because you should have age-based, matrix-based, and utilization. Say for example, if you want to do screening purpose, is your screening purpose, your reference range will change. If it is for the management purpose, say for example, your phenylalanine level should not be exceeding 600 in a non-phenylketonuria case. Purpose is different, right? HPLC, only HPLC is very challenging, I am telling you. But if you get expertise into HPLC, nothing best than that. You can blindly use LCMS. Like a baby playing with a toy. Okay. Test interpretation, I told you, there should be 2-3 platforms available. Okay. Say PKU, you should have GCMS finding or LCMS finding with you to call it as PKU. MSUD, you should have branch and amino acid elevated in the urine. Branch and keto acid is in the urine, branch and amino acid in the blood. Homocystinuria, you should have homocysteine estimation to be done in the serum or plasma. Because homocysteine and methionine are treated same. You don't have homocysteine in the kit. Okay. Tyrosinemia also, you should have succinylactone. Okay. So IVA, you should have isoallyl glycine. I told you how glycine is synthesized. It is just like carnitine. Isoallyl carnitine is secondary biotransformation. Conjugation reaction, same like glycine. Okay. Organic acids, beautiful platform. I love this platform. Why? Because most of the organic acidemia are intoxication effect, first class. Okay, they are covered by GCMS. So selection, if you are suspecting MMA, PA, BKT or PKU, okay, or organic acidemia for that matter, okay, isovaleric acidemia, this is best platform. HMG-CoA lyase deficiency, beautiful fingerprint, you will get it on GCMS. Okay, so GC and MS. MS is a detector. GC is, you have to make it volatile. Maybe different platform, methods are available to make it volatile. Metabolite are volatile and swap to GC. GC column usually is 50 meter. Okay, it is given to the MS and MS detects all. The most volatile comes first and most reluctant or less volatile comes in the last, elute in the last. Simple chromatography. Don't keep on doing paper chromatography, please. Okay. age old. We are doing paper chromatography. Okay. So this single test does screening of so many disorders in one single test. Okay. So this is gold standard, I told you. And specimen requirements, utility. Urine to be transferred in a liquid form is very difficult. But dried urine sample, filter paper, pour it on filter paper, dry it, send it. Beautiful. Urine creatinine you have to estimate because you should know the denominator. This is semi-quantitative test. Absolute quantitation requires internal standard. You don't have, right? An internal standard, for every run you have to add one internal standard. And these are the commonest internal standard used. Heptadecanoic acid, C17, margaric acid. Chemical derivatization is required and temperature ramp is required. And isotope dilution gives accurate quantitation. And you have to define the BRI based on your platform. And data analysis and interpretation is excellent. Okay, I will love if somebody is interested to go for GCMS. Okay, with my expenses, I will come down to your institute and set up you. Not a problem. Okay. Validation and PT participation. GCMS, you have R&D. Beautiful. And CAP also provides the participation. Homocysteine estimation is one of the application of LCMS. You can exploit it. Serum homocysteine is not so accurate. CDG, have you heard of this? ACLO, mono, di, tri-CLO. If ACLO and di-CLO are more, it is called glycosylation defects. These are group of disorders. Almost 100 plus disorders are identified till date. Porphyria profile. This is also an LCMS application. Okay. Because of paucity of time, I am running through the application. And this is steroid profile. Second tier testing if you have 17-hydroxyprogesterone elevated. Okay. Especially deficiency of cortisone and aldosterone. Right now. So here ratios are actually playing the role. And this is one of the application ma'am has said. Okay. Estimation of only 3 metabolites. Creatine, creatinine and gonadinoacetic acid will give you the screening of creatinine, neuronal actually, cerebral creatinine deficiency syndromes. Other techniques are also there, LSD by LCMS, CSF amino acids, really helpful for NKH to get the ratio. Electrophoresis is also useful. Molecular I haven't touched because I am into biochemical genetics, so I will impinge upon that. And I touched this untargeted metabolomics just to give you an overview. This is one of the, we just initiated one project with NCBS. Okay, TIFR. Do you know NCBS? It's in Bangalore. They are having NMR platform, nuclear magnetic resonance. Okay, ma'am, you also talk with them. They have untargeted metabolomics and they are charging hardly 400 or 500 rupees per sample. If you have a list of say one clinical diagnosis, say maybe any condition for that matter, doesn't matter, doesn't matter. Okay, you do that analysis, you preserve those sample, give it to NMR people, they will do almost thousands of metabolites into that sample and they will tell you these are the metabolites which I have found different than the normal population. That becomes a fingerprint for that disorder. Okay, so we are doing for 3 disorders, those neurodegenerative disorders. One is Parkinson's, Alzheimer's and CJD. That we are actually doing currently. That is one of the project for the next 2 years. So NMR is one of the excellent platform for untargeted metabolomics and finding out new surrogate markers, serum markers for the blood. Okay. These are the EQA available, you might be knowing. CAP, then R&D for urine. R&D is having everything actually. CAP is also having almost everything. But problem with CAP is that they don't have DBS based program. For PT, okay, CDC is having almost everything. But they don't have urine sample, urine or GCMS analysis. Taiwan, they have G6PD, very good program. Excellent program. I love that program. Koreans also have very good program. They are also having everything in their ECAS program. And UK ECAS, I don't recommend them because they are very costly. Very costly. They are having everything, but it is very costly. Okay. To initiate with, like SRMC are doing for basic screening. You are also, I think you are in CDC, right? Okay. We are also into CDC. But I initiate for 5-6 parameters, 2-3 parameters. You start it. Okay. I'll help you out how to negotiate it, how to deal with those vendors, and how to set up in your lab. But please, for God's sake, if somebody is really fascinated or got some insight into this, okay, I encourage you people that you should initiate 1 or 2 single disorders as one of the responsible physician in this at this forum. Okay. With this, I thank the management, the organizers, and everybody here. Thank you very much.
Thank you so much, sir. That was a superlative way to just explain the subject, and it was really a lot learning, sir. I request Dr. Kannan and Dr. Padmalata, Madam, to spell a few words about the session.
Good afternoon, everybody. Thanks to Dr. Mahesh Harichandra Hampe for this elaborate and interesting talk about a boring topic. Really, you did a great job, sir. Thank you, and thank you for your time management. And thanks insist on hypothyroidism screening. Thank you, and also about your importance of screening IAM and holistic action of filter paper and its diagnostic in IAM, sir. Thank you. Sir's speech has kindled interest in the IAM. Thank you, sir. Thank you for your speech.
Just one doubt, ma'am. Sir, we have a case of, sir, Humpy, sir. You want water? We have a case of creatine deficiency syndrome. Do you have a facility like to do NAA? Yes. Do you have the facility for that? Creatine deficiency syndrome. So by which method do you do that? Tandemas only.
Hi. Probably if you think, you can send it to Yoda Diagnostics currently because they are having very cheaper cost. Because, okay, we'll talk it later. I will definitely share
So
the cost
it was
details.
identified on MRS, like, no, yes.
So you have deficient creatine level or guanidinic acid is elevated. Okay, fine, ma'am.
I now request our Honorable Dean Madam, Dr. Tilagavati, to felicitate our chairpersons, Dr. Kannan and Dr. Padmalata, and also our RMO Madam, Dr. Pungode. Thank you, ma'am. I welcome our next eminent speaker, Dr. Cherian, Professor of Radiology from our Government THIRUVALLUR Medical College and Hospital. Sir has graduated MBBS from Chengalpattu Medical College, He further obtained his DCH and MD in radiology from Stanley Medical College and Madras. Was awarded observership at Department of Neurointerventional from SRMC. He is also a core committee member in BRACE CME. We welcome Sir to speak about neuroimaging and inborn errors of metabolism. I also invite Dr. K. Geeta, Associate Professor of Department of Biochemistry from Government Kilpak Medical College, and Dr. Sarath Babu, HOD of Department of Orthopedics, Government THIRUVALLUR Medical College, to chair the session.
Yes, sir. Can.
Okay. Good afternoon, everyone. At the outside, I like to thank the Department of Biochemistry, especially Dr. Prem, to giving me this opportunity. Varlaba? Okay. So I'm going to concentrate only on neuroimaging. The radiological part is completely different from the classification which you were learning since morning. Okay. What we say is it's a parallel learning. The way we classify and we approach these diseases is a bit different from what you were taught since morning. So we basically know that there is a problem with the metabolic pathway. Okay, metabolic pathway, or it affects the cellular organelles, and there is a wide range of clinical spectrum. This is a mimicker of so many other childhood problems or on adult issues, disorders like sepsis, infections, and other things. So James Barkovic was the pioneer who has a different image-based approach, and we classify based on the anatomic location where it is affected, and also with specific imaging features. So when you suspect IEMs, so first thing is you exclude the mimickers, and then whether it is predominantly a white matter disease, that is a leukodystrophy, or a gray matter disease, or poliodystrophies, it is mixed gray and white matter disease, that is pandystrophies. So now within the white matter, whether it is hypomyelination or demyelination, and whether the subcortical U fiber is involved, whether there is a global involvement or whether there is a periventricular involvement of the white matter, all these things should be taken into consideration, even whether the frontal part of the brain is involved or the posterior parieto-occipital part is involved. And coming to gray matter, whether the corpus striatum is involved, which part is predominantly involved, or whether the cortex is involved, and pan-leukodystrophies, again the combination of both these things. And before we go into the proper things, I like you to understand the basics. Okay, this is a T2 image, T1 image, and this is a FLAR image in MRI brain. So in a T1 image, the gray matter will be gray and white matter will be white. White in the sense it is a lighter gray of the spectrum. And in T2 image, the gray will be gray, but the white matter will be dark. Okay, if it is bright here, it is abnormal. Okay, the FLAR is also again a T2 image. Here the fluid will be bright, we suppress the fluid and get the FLAR image. So the gray matter will be gray and the white matter will be dark. And some basic anatomy. So we have, this is the head of the caudate nucleus, and this is the putamen and globus pallidum, that is lentiform nucleus, and this is the thalamus, and this is the internal capsule. This is genu and splenium of corpus callosum, and you can see there is a uniform thickness of gray matter here, and if it is thickened, it is pachygyria, and if it is small and multiple projections, small multiple projections, it is polymicrogyria. So I am explaining these things so that you will understand my for next slides. And one thing you have to understand is there is a constant development and myelination which occurs during the childhood. So the myelination will be complete and it will be adult-like at around 2 years of age. So you can see this is a T2 image. We expect a darker white matter, but still at 2.5 months, this white matter is not yet myelinated. But at the same time, at 1.5 years, all these white matters will be myelinated. So, but how will you differentiate between these two things? At a younger age means the volume of the white matter. The volume of the white matter is normal. There is no loss of volume matter, or it is not swollen. Similarly, you can see the gradation of gray is becoming brighter because this is a T1 image. As the myelination proceeds, it becomes brighter. The brain becomes brighter, and the thickening of corpus callosum is seen normally. And even at 20 to 40 years, you can have terminal zones of myelination. These are the terminal zones of myelination. This is a normal variant. So you can see a white matter hyperintensity there. But usually these terminal zones of myelination won't reach up to the margin of the ventricles. So this is not an abnormal but a normal variant. And regarding MRS, it is similar to your mass spectroscope or electrophoresis pattern study. So we have various metabolites, and its concentration is represented at various different frequencies or ppm. So you have to understand all the metabolites. For example, NAA means usually it is representing a healthy neuronal marker. It is a healthy neuronal marker. Wherever there is a neuronal damage, the NAA will decrease. But one disease in which the NAA is pretty much increased is Canavan's disease, that is pathognomonic finding there. And another thing is in mitochondrial diseases, whenever it is affected, so there is an oxidative phosphorylation is happening there. You remember like that, there is some anaerobic respiration happening there. So naturally the lactate will increase. Again, when there is a cellular death, the lipids will increase. In case of amino acids, directly you can see the rise in amino acids, branched chain amino acids at this ppm. So if you understand what is the role of each metabolite and whether it is elevated or decreased, you can understand the disease. So now we can see what are all the predominant white matter affected diseases or leukodystrophies. First, you have to understand the difference between dysmyelination, demyelination, and hypomyelination. So hypomyelination, there is a delayed myelin maturation. Demyelination, there is a normal maturation after which it is destroyed. But the dysmyelination, myelination occurs, but it is an improper or an abnormal myelination. So we can rush through the diseases now. You have to understand the basic anatomy and the MRS pattern, then you can easily go away through this. So this is an X-linked dystrophy, and pretty well you know all the clinical findings will be almost similar for all the IEMs. And there are two forms, classical and conatal. Conatal is very severe form, and here you have a diffuse or patchy white matter involvement. And in MRS, because there is a neuronal damage, the NAA is decreased. In very severe cases, the cell membrane is lost and the choline is decreased. So you can see this is we expect this is a normal brain. So the white matter should be dark, but you can see that it is all white here. So, and you can also see there is a thinning of corpus callosum and a loss of volume in brainstem. So, and MRS shows a decreased NAA, but the choline is normal. So again, most of the places, whenever a white matter disease is there will be penetrating vessels or venules within the brain matter. So around that area, it is very important. For example, here around the venules, the myelination is not affected, but rather rest it is affected. But in case of acquired demyelination like multiple sclerosis and all, perivenular affection will be there. So that's why you will get some oval hyperintensities along the venules. So this gives a typical leopard skin-like appearance. So another disease with a similar leopard skin-like appearance, but whenever you see a similar appearance, you should think of metachromatic leukodystrophy, because that is the most common inherited leukodystrophies. When you see a white matter hyperintensity suspected in IEM, you think of metachromatic leukodystrophy, and it is a lysosomal storage disorder. Other things you would have seen about the clinical scenario and appearances. But one thing from radiological point of view is late infantile, the predominance is posterior. In juvenile and adult, the predominance effect is anterior or frontal. So you can see white matter hyperintensities both sides. This is a juvenile or adult form because the frontal is predominant than the posterior aspect, and this is a typical butterfly shape. So classic butterfly shape, which you can see. And again, similarly, perivenular sparing of demyelination. So it will give a typical leopard skin appearance. Or if the if the venules are parallel to this axial plane, you will get a tigeroid appearance. Okay. So tigeroid appearance. Sometimes you might get a cranial nerve enhancement in few cases, and also there can be a thickening of optic nerves here. So when you say thickening of optic nerve, the more appropriate diagnosis is Krabbe's disease. And the tiger pattern, other causes of tiger pattern is Pelizaeus-Merzbacher or ADEM. An optic nerve thickening, Krabbe's disease. If you see an optic nerve thickening, I'll think of a Krabbe's disease rather than MLD, because it is more commonly seen there. And in MRS, naturally there is a neuronal destruction, NA is decreased, there is an increase in myoinositol and lactate. So lactate peak, even if there can be inverted peak, that is also considered as a elevation. So now anterior involvement of white matter is a juvenile or adult type MLD, and posterior it is infantile MID, which is much more common. And X-linked leukodystrophy, here it is a peroxisomal disorder, and there are three zones like a fire. There is a burnt out zone, there is an active burning zone, and another ready to burn zone. So this burnt out is necrotic, and the intermediate zone is active demyelination and inflammation. If you give a contrast, it will enhance with contrast, and in diffusion weighted imaging, it will be bright. And the periphery to that is the demyelination without any inflammation. So again, there is a classic X-linked ALD that is more common form, that is 45%, and it affects the preterm boys. And there is another adrenomyeloneuropathy, that is the second most common form, and it can present as an Addison disease without any involvement of CNS. Again, same thing, the three zone phenomenon, that is, this is a posterior predominant pattern. That is very important, and it spreads from posterior to anterior and central to the periphery. Okay, and with the MRS, sometimes you might see the peak of very long chain fatty acid macromolecules at 0.8 to 1.4 ppm, and otherwise there is a decrease in NAA and increase in lactate. For all these diseases, there will be decrease in NAA because of the neuronal damage, except for Canavan's disease, where this is disproportionately increased when with respect to the choline integral values. Again, this is a posterior predominant. There is an enhancement of the active margin. So again, there is another form that is that affects corticospinal tract, that is the pyramidal tract. You can see that, and also the first place to affect is splenium usually. And MRS, you can see a lactate peak and decrease in NAA, and this is a peak of very long chain fatty acids. Doing an MRS is very much dependent on the technician's knowledge and correct anatomy and everything is very, very important. Even when they basically take a T2 image or a 3D T1 image and then they plan for a MRS. If the patient moves a little bit during taking MRS, the whole thing may be abnormal. The whole thing can be missed. Again, same thing. So posterior, it is classic ALD. There is a frontal variant of ALD also. So early corticospinal tract involvement can be seen in classical ALD. And Krabbe's disease. So it is a globoid cell leukodystrophy. It is common in female, and again 3 forms: infantile, juvenile, and adult form. And you can see a thalamic calcification, thalamus calcification often seen. So it is a mixed gray and white matter, but predominant leukodystrophy. And you can see there is a periventricular white matter hyperintensity, and these are the, between the gyri, these are the association fibers that is called as U fibers that is paired. Okay, and you can see there is a effect of the posterior limb of internal capsule and also crus cerebri, corticospinal tract and medial lemniscus in the pons. The typical finding is a thickened optic nerve, and this is the optic chiasma, which is thickened. Optic nerve and optic chiasma can be thickened in Krabbe's disease, most commonly seen in Krabbe's disease. And in dentate nucleus, so there can be a peripheral hyperintensity with a central hyperintensity, which will give us a sandwich sign. And MRS is non-specific, mostly an increase in choline and dip in NAA. So white matter with thalamus, it is Krebs disease, and also posterior predominance is Krebs. So vanishing white matter, this is a global involvement of white matter, and this is also known as Crease leukoencephalopathy whenever there is an early onset. Whenever there is an early onset, it is a very progressive disease. I'll show you the images. And usually the basal ganglia, basal ganglia is paired, and sometimes corpus callosum, anterior commissure and internal capsule are also spared. So you can see the predominantly all the white matter is including the subcortical U matter. It's a global involvement of white matter. You can see this is a T2 image. We expected darker white matter, but including this U fibers and the periventricular, and the whole of the thing is involved. So you can easily differentiate the other claustrum, everything here. Same thing. Again, see this onset, younger onset and early damage, and the white matter is replaced as fluid. You can see the CSF within the ventricle is equal to the white matter. So early the onset, the more faster and cystic white matter decay is there. Late the onset, there is a white matter atrophy, gliosis predominates. The main differential diagnosis is Alexander's disease, but Alexander's will have macrocephaly and a fronto-occipital gradient. This is all global. The other global involvement of white matter is Van der Nap's disease, and this also has a megalencephaly, the subcortical U fibers and everything is involved, but the typical thing are subcortical cysts in the anterior temporal region and also in the frontoparietal lobes. Okay, you can see the cysts there and the white matter involvement, and the white matter involvement will give a swollen appearance of gyri most of the times. So global involvement is vanishing white matter and Van der Nap's. PKU, it is the most common inborn error of amino acid metabolism, and so you can see during an active phase, it is a periventricular white matter involvement, predominantly in the frontal. Here it is in the peritrigonal region. So this is a finding, and you can see a elevated peak of phenylalanine at 7.37. So it is not usually seen in our routine MRS. You have to change the TE and do a specific study when you suspect. So the radiologist should sit during the during taking the MRI, and the technician should be smart enough to do the proper study. And MSUD, again, it's a branch chain amino acid issue. And the main problem here is an intramyelinic edema will happen because of the accumulation of this amino acid and water. And there is a vasogenic edema. So even though there is some brightness in the diffusion weighted images, there won't be any restriction usually. And usually it involves the cerebellar white matter, peduncles, brainstem, and posterior limb of internal capsule, thalami and globus pallidum. It involves both deep gray matter and also white matter, and perilorlandic cerebral white matter. So you can see this is the medulla, cerebellar white matter, cerebellar peduncles. This is midbrain. Again, thalami. It also includes you can see the thalamus is involved. It should be dark like this, the thalamus and also globus pallidum. So it is pairing the putamen and the head of the caudate nucleus. And this is the internal capsule, and this is the perilorlandic cortex, which is also affected. And again, you can see at this point, 0.9 to 1, to be particular 0.97, there will be a peak because of the branch chain amino acids. So these amino acid peaks are also seen in pyogenic abscess, in MRS. So globus pallidum with white matter involvement, you think of MSUD. So this is predominantly gray matter. It can be either cortex or deep gray white matter. So cortex, it is Rett syndrome, and deep gray nuclei, it is PKAN, Wilson's and Menkes. These are the common diseases. I'm not covering the entire spectrum, a few of them. And Haller-Roden-Spatz disease, it is not, now we are not following this Haller-Roden-Spatz disease because Spatz was a physician in Nazi Germany, and he was working in a euthanasia camp. Okay, they used to kill they want to cleanse the Aryan race, so they used to kill all the people with physical or mental disability, and they used to do researches with them. So that's why we stopped using that name. But instead, pantothenate kinase associated neurodegeneration. So most of the cases are diagnosed late in the first decade, and other clinical thing you can read. And it usually involves globus pallidum, substantia nigra, dentate nuclei with or without red nucleus. So you can see it has affected the globus pallidum, okay, and also substantia nigra. So whenever there is a gliosis within the globus pallidum, it gives a typical appearance of a eye of a tiger. So this is a typical appearance of PKAN. And Wilson's disease, he said, Dr. Hampe said about the KF ring, which is pathognomonic, okay, and usually it affects the basal ganglia. The corpus striatum is involved, and also midbrain is involved, and with ventrolateral thalami. And these are the clinical manifestations. You can see the involvement of the thalamus, caudate nucleus, and the lentiform nucleus. Okay, same thing is seen in FLAIR and CT images. And when brainstem is involved, and this is a midbrain, the red nucleus and substantia nigra, and the rest of the tegmentum becomes bright, sparing the red nucleus and the substantia nigra. This gives a typical face of giant panda sign. Okay, there is another sign. If you go a little bit lower at the bones, at the level of superior cerebellar peduncles, you can see the pontomedullary fibers, pontocerebellar fibers may be spared, and it forms the eyes, and the junction of aqueduct and fourth ventricle will appear like a mouth and the nose, and the cheeks will be the superior pontocerebellar peduncle, and it gives a miniature panda appearance. So Menkes disease, you have to think about the hair. That is a typical kinky hair, then you should also think about the kinky vessels. The problem with this tortuous vessel is the patient may have a subdural hemorrhage and a subdural hygroma because of this. Some MSK changes will also be there. You can see it is an white matter disease. It also involves the corpus striatum. This is subdural fluid collection secondary to the previous hemorrhages, and you can the angiogram also shows multiple tortuous vessels, and MRA also shows multiple tortuous vessels. And cortex, it is Rett syndrome. Usually it occurs in girls, and the patient, the first initial growth will be normal. After that, the cranial, the skull size decreases and causes microcephaly. Patient may be mistaken for autism. They have associated MSK changes. There will be a thinning of cortex in the frontal and anterior temporal cortex. Okay, so corpus striatum involvement in PKAN and Wilson's disease. Canavan's disease, this is a spongiform leukodystrophy. There is a deficiency of N-acetyl aspartoacylase. So the patient will have a macrocephaly, and this thing starts with the involvement of subcortical arcuate fibers or subcortical U fibers first. Usually other things will start with the periventricular, goes from central to the periphery. This is periphery to the central, and it may extend. Usually it will spare the caudate nucleus head and putamen, but it involves the thalamus and globus pallidum. Okay, this is the pathognomonic picture, MRS picture. This is the choline. With respect to the choline integral value, it will 2 or 3 times larger. Usually it is the peak is larger than choline, but the ratio, so choline NAA ratio and creatinine NAA ratio, that thing changes. So Alexander disease, it is also called as a fibrinoid leukodystrophy. There is a macrocephaly, anterior frontal involvement, and there is a classical finding of periventricular rim which is not involved, and eventually it leads to atrophy of medulla and cord in case of adult form. So you can see there is a frontal involvement, and you can see the hypointense rim which is not involved around the periventricular region, and you can see the atrophy and thinning of medulla and cervical cord. So white matter with globus pallidum in MSCUD and also Canavan's disease. White matter with corpus striatum, mitochondrial diseases, which we will see. So Zellweger syndrome, so it has ventricular enlargement or area, and also there is cerebral be seen even in infancy. Can you see transcranial ultrasound? You can see the cyst in the caudothalamic plane. This is subependymal. And also there will be a, you can see this is a normal gyral pattern. Can you see a small projections, multiple small projections? It's a polymicrogyria. And you can see there is a pachygyria. Pachy means thickening. So you can see a thickening of the gray matter. So we also include mucopolysaccharidosis under this. You can see these perivascular spaces or Virchow-Robin spaces. They are all very much prominent and dilated. There can be white matter changes in the peritrigonal region, and there will be hydrocephalus and brain atrophy. So actually this is MPS is a straightforward diagnosis. We don't need an MRI to diagnose that. And Leigh syndrome, it is a subacute necrotizing encephalomyelopathy. So here the brainstem, periaqueductal gray matter, medulla and midbrain is involved. But putamen, it is characteristic if putamen is involved, but it is not usually always present. Okay. So in MR spectroscopy, again it is the usual. So elevated lactate, elevated choline and reduced NAA. So Leigh syndrome, you can see the involvement of thalamus here. And also this is periaqueductal region. This is the dorsal midbrain, and thalami is also involved. This is the medulla, and same thing. After a long time, there is a fluid density in CT. You can see in thalamus loss of volume and atrophy. Melas acute, it looks like a stroke-like episodes will be there, and as the name suggests, there will be stroke-like episodes and lactic acidosis. So naturally, the lactate levels will increase in MRS. So this won't follow a typical vascular pattern. For example, this is a typical acute infarct in a PCA territory, but you can see the difference, no? So it is somewhat different from it doesn't follow a vascular territory, and swollen gyri will be seen. Subcortical white matter is involved, and the change is usually vasogenic edema rather than a cytotoxic edema, and that's why you don't see a diffusion restriction. So chronic infarcts, it is symmetric or asymmetric. In case of subacute phase, there is a black toenail sign, and parieto-occipital, parieto-temporal regions are usually involved, and you can see a lactate peak. So chronological change is a calcification of putamen, that is a characteristic, and you can see in subacute phases, you can see a swollen gyri with a dark spot which looks like a black toenail sign, and glutaric aciduria, it is an organic acetopathy. Other symptoms you can see, but the thing here is that it has a very variable clinical presentation, and lab investigations are not always diagnostic. So MRI is going to help in some way or other, and there is some macrocephaly in early infancy. So there is an initial swelling of basal ganglia followed by atrophy and necrosis. There is a widening of sylvian fissures. So lactate peak will be there in acute phase. You can see the acute phase, the basal ganglia is swollen. It is not normal. It is bright in, then followed by atrophy. So DD of macrocephaly is with respect to IEM is Alexander's, Canavan's, and glutaric aciduria, and Van der Napp disease. And bilateral basal ganglia hyperintensities in so many diseases will come. And main thing is benign enlargement of subarachnoid spaces. It's a normal finding in an infant. You should not get confused with the atrophy and that. And non-accidental injuries, because these children are also prone for subdural hemorrhages. Thank you.
Thank you, sir, for throwing light on the radiological aspects of dealing with inborn errors of metabolic disorders in the newborn. I request Dr. Geeta ma'am and Dr. Sarath Babu sir to provide your valuable feedback of the session.
It's an elaborate white topic that is put in a nutshell, sir. Classifying into white matter and grey matter disease, and the elaboration of each disease is very nice, sir. At what point of time we can diagnose, how early we can diagnose this IEM, sir?
Actually, MRI is not diagnostic most of the times. Only in few conditions when there is a confusion and there is a difficulty. But usually what they do is, whenever they send the blood for investigation, they correspondingly do MRI to give they want us to give us some insight about the thing. For example, if Na is elevated, that is it. That is Canavan's disease. So certain things will be very, very helpful. Otherwise, in adult and juvenile, they will have a difficulty. They won't think of, in newborn and infancy, they will think of IEM. In adult and juvenile, first thing is they don't think of IEM. Yes. Their radiological input is very important.
Is it in any scenario, ultrasound is better than MRI, sir, in detecting this?
No, it is typical neuroimaging. MRI is always better.
Any doubts?
It is more than it's a negative predictive value is high.
Any doubts? I think we can break up, sir, for lunch.
So thank you, sir.
highlighted all the important features of the salient radiological findings, and it was useful. And also they will be enlightened with all those faces, giant panda faces, all those tigroid faces. So it will be helpful for all of them. And to narrow down the differential diagnosis, combining the radiological features with the clinical features and the investigation, it is will be very useful. Thank you, sir.
Now I request Dr. Pramila ma'am to felicitate our chairpersons, Dr. Geeta ma'am and Sharad Babu sir. And also I request her to felicitate Dr. Cherian sir.
Thank you, madam. Now we will break for lunch. As we are running short of time, lunch break is restricted to half an hour. Faculties can join for lunch in the 5th floor MEU unit, and students can have their lunch in 5th floor examination halls. Thank you.